annulus, the left anterior fascicle, or the posterior papillary muscle. Once the quadrants are localized, the precordial transition of these PVCs suggests the likely origin. In case of PVCs with RBB morphology, the transition from positive to negative occurs early as we move from apex towards the base. In PVCs with LBB morphology, the transition from negative to a positive occurs early as we move away from the free wall towards the septum. The left quadrant structures are the inferior mitral valve annulus, the posterior papillary muscle, and the left posterior fascicle. Idiopathic PVCs can be differentiated arising from these structures on the basis of precordial lead transitions, QRS morphology, and lead V1. An RS ratio greater than 1 in V6 suggests a more basal location, which is seen in PVCs arising from the mitral valve annulus. An RS ratio less than 1 by V5 usually suggests a posterior papillary muscle or a left anterior fascicle origin of PVCs. RSR pattern and a QRS duration of less than 130 milliseconds suggests early recruitment of the His-Purkinje system seen in PVCs from LPF. Cardiac crux is an epicardial space where all four chambers of the heart are in closest proximity. It's also the junction of the MCV and the CS. PVCs from this area have a left superior axis and early V2 transition and features suggesting of its epicardial origin, pseudo delta or the maximal deflection index of more than 0.55. The moderator band is a free-running muscular structure extending from the anterior septum to the anterior papillary muscle of the foot, right ventricle free wall. PVCs originating here have a left superior axis and a later than V4 transition. Tricuspid valve PVCs have variable precordial transition from V2 to V4 anywhere between these leads depending on their septal or lateral aspect of origin. The inferior lead discordance are seen in mid-cavitary structures. Two kinds of inferior lead discordance are noted. Positive negative discordance, which is a positive deflection in lead 2 and negative in lead 3. Negative positive discordance is negative in lead 2 and positive in lead 3. And the positive negative discordance are seen in RV structures and the maximal deflection index is interval between the earliest ventricular activation and the maximum deflection in each precordial lead. Taking the shortest interval is divided by the QRS duration. An MDA of greater or equal to 55 milliseconds had a high sensitivity and specificity to identify an epicardial ventricular tachycardia origin in patients without structural heart disease. In summary, with the diagram kept in mind in the background, this paper easily helps to approximate a localization of a PVC origin in a structurally normal heart. The same idea can be applied to a diseased heart, but it will be approximating the exit site of the PVC. All RV structures are not right-sided and all LV structures are not left-sided. Broadly, PVCs can be divided into those with superior and those with the inferior axis. Lead 1 further divides the inferiorly directed PVCs into right or left-sided origin. The bundle branch morphology and the precordial transition is useful for the superiorly directed PVCs. Inferior lead discordance and epicardial origin are additional things to remember. Thank you.
Thank you, Dr. Kamal Sharma and team, for having me here to speak on the topic of localization of pathways. I would stick to the basics of narrow complex tachycardia and localization of the tachycardia based on tachycardia ECG. The first step is to differentiate between AVNRT and AVRT based on the P-wave morphology, QRS alternance, STT changes. Then you can localize the pathway site based on the P-wave morphology and the STT changes. And based on sinus rhythm ECG, the pre-excitation, when you can localize the pathway. So step 1 would be first to differentiate in AVNRT and AVRT in a narrow complex tachycardia. Step 2 would be locate P waves and localize based on it. Step 3 would be location based on STT changes. And once the sinus rhythm is achieved and there is pre-excitation, step 4 would be localization based on pre-excitation. So how to differentiate between AVNRT and AVRT? AVNRT, the ECG shows R prime in V1 and pseudo S in inferior leads. That is because of the retrograde P waves in the terminal part of the QRS. The rate is generally of 150 to 200. The P waves, if seen, are negative in inferior leads and one-to-one AV relationship is not mandatory. While in AVRT, STT changes are present because possibly of P waves falling on the T waves. QRS alternance may be seen, the rate is faster, and if seen separately, P wave morphology can help in localization. 1:1 relationship is mandatory. AVNRT is basically from the AV junctional area where there is a slow pathway and a fast pathway, and a typical AVNRT is a slow fast AVNRT. Here the P wave overlaps with the QRS complex and as activated at the same time. So therefore you may not see P waves at all the time, or if it is present, it is in the just at the terminal portion of the QRS as R prime and V1 and pseudo S and inferior leads. So seeing this tachycardia ECG, you see this R prime and you see the S waves in 2,3 AVF. When the tachycardia terminates after carotid sinus massage, you don't see this R prime and the pseudo S waves. So therefore, this becomes a typical AVNRT. So comparison between the two same R prime which is present and the pseudo S which is present in this patient is not there. This is typical of a typical AVNRT. What about AVRTs or related to WPW? They are generally short RP tachycardia most of the times. P waves are separate from the QRS on either the ST segment which causes the STT changes, or they can be on the T waves causing a T wave notch, or a separate P wave may be seen differently. So there is a pathway separately other than the AV node. It's an orthodromic AVRT resulting in a narrow QRS. So antegrade goes via the AV node, retrograde goes via the pathway, and this completes the circuit. So let us see this tachycardia ECG here. Narrow complex fast tachycardia. You can see QRS alternance, there's no R prime, but there is a notch on the T wave if you can see, but the P wave is not very well appreciated. QRS alternance is here also, and therefore likely to be AVRT. The tachycardia when terminates shows a baseline short PR interval with pre-excitation, R wave being positive in V1, therefore suggests WPW. So what about the tachycardias with accessory pathways? It can be orthodromic tachycardia, which we commonly see, or it can be antidromic or a bystander. So we'll discuss more about orthodromic tachycardia. It is generally re-entry associated with WPW. There are other forms with their antidromic tachycardia like MAHEM and a PJRT, which is a slow kind of retrograde conducting pathway. So important is the ventricle forms a part of the circuit. The ventricle is a part of a circuit. So the step 2 is when you can see the P wave morphology. Now here in this tachycardia, it's a narrow complex tachycardia, and you can see that this P wave is inverted into 3 AVF, which is causing the ST segment to be there, and there is a bump in the T wave which is possibly positive. So if you have this kind, it is suggesting that the P wave is retrograde coming from the inferior area, and therefore is likely to be an inferior pathway. Based on the STT changes, if you have significant STT changes in the inferolateral leads, that means the P wave is somewhere there, and therefore the pathway is likely to be in the infralateral area, maybe the left lateral or left posterolateral. In a long RP tachycardia where the P wave is separately seen, here you can see a slow tachycardia ongoing, but the P wave morphology is 2,3 AVF is negative and V1 is actually positive, suggesting that it is arising from near the AV nodal region and likely to be a PJRT, a long AV tachycardia. To confirm this, a carotid sinus massage terminating the tachycardia suggests that it's a AV nodal dependent tachycardia. Now coming to the last step, that is localization based on the sinus rhythm, pre-excitation as a must. Either it's a left-sided or a right-sided arrhythmia, and the differentiation between the areas is as mentioned in this figure, but we'll go with the localization. Most commonly is in the left lateral region and then goes to the posterior, then right side and the anterior region. So the WPW ECG characteristics as shown in the ECG are short PR interval in sinus rhythm, QRS being wide, more than 120 milliseconds, a delta wave which is a slur in the start of the QRS, and STT changes are present because of secondary QRS widening. The localization based on ECG, the presence of pre-excitation is a must. Algorithms from 1945 by Rosenbaum et al. To right now, there are many algorithms. The limitations are inter-observer variation and non-producible results by independent different studies. You need to have a good amount of pre-excitation, and the QRS should be more than 120 milliseconds. Initial delta wave of 20 to 40 milliseconds is a must. There may be difficulty if there is an isoelectric start, or defining the morphology is difficult. If there are multiple pathways in structural heart disease, it becomes difficult to localize. So let us see the basic types of localization. So Rosenbaum in 1945 had the seminal paper showing the types of pre-excitation. So in short, if you have a positive R wave in V1, that is RBBB, it's a left-sided pre-excitation. And if you have a LBBB in V1, then it is a right-sided pre-excitation. Inferior leads negative, that means it's a posterior pathway, and inferior leads positive means it is an anterior pathway. Then came the Milstein algorithm, then is the Arruda algorithm, and many other algorithms being there. But I would like to discuss this algorithm for localization, which was given by Pamberg and Hassegray et al. And the step 1 remains the same. If V1 is positive, it's mitral annulus, V1 negative, tricuspid annulus. If you have V1 which is positive and you think it's a left-sided, then step 2 would be how many inferior leads are positive. More number positive, that is all 3 positive, 2, 3 AVF, then it becomes a superior placed or left lateral pathway. If there are 1 or 2 which are negative, then it becomes a posterolateral area, and if all are negative, it becomes a posteroseptal or a posterior pathway. To differentiate between posterior, lateral and a posteroseptal pathway, the ratio of V1 to 1 is important. If V1 is taller than lead 1, that is the ratio is more than 1, it is a posterolateral pathway. If the V1 by lead 1 R wave ratio is less than 1, it becomes a posteroseptal pathway. And if there is a notch in the descending limb of lead 2, then it may be a deep cardiac pathway. So carotid and coronary sinus pathway. Going to the right side, the tricuspid annulus, if V1 is negative, then you go to this again the inferior leads, 3 positive showing that it's a right anterior or a right anteroseptal, 1 or 2 positive right lateral or right septal, and all 3 negative means right posterior or posteroseptal. How do you differentiate between these septal versus the lateral is where the transition is. If the transition is in V2, then it is likely to be septal. If the transition is V3 and more, then it is likely to be a lateral pathway. So this helps us localize the pathway when there is pre-excitation. So let us share some examples. Step 1, V1 positive, left side, then step 2, 2, 3 AVF positive. That means it's a left lateral pathway. If 1 in AVL is negative, that means it's a left high lateral pathway. Again, pre-excitation, V1 positive, V2, so all 3 are positive here, again left lateral, but here 1 and AVL are towards more positive, and therefore it becomes a total left lateral rather than a high lateral pathway. Again V1 positive, and here you can see that 2, 3 AVF are equiphasic, they're not totally positive, while 1 is positive. You can see that this is a left posterolateral pathway. Here the lead V1 is more positive as compared to lead 1, and therefore a left posterolateral pathway. Again V1 positive, but 2, 3 AVF being negative, so it becomes the posterior region, and here the ratio of lead 1, so 1 is more positive as compared to V1, and therefore becomes a left posteroseptal pathway. The next is a V1 positive, and what you see again is a 2, 3 AVF negative, so left posterior. 1 is taller than lead V1, and therefore it is a left posteroseptal, but there is a notch in the descending limb of lead 2, suggesting that this is a left-sided pathway. However, it can be in the deep coronary sinus. When V1 is negative, then you see for 2, 3 AVF, and all 3 are negative here, suggests that this is a left posterior pathway. The transition being in lead V2, therefore it becomes a left posteroseptal pathway. Again, here the pre-excitation V1 is negative. The step 2 would be to 3 AVF. So here only 2 is positive, but 3 and AVF is negative. Therefore, it's likely to be left posterior, and the transition is basically in more than V3, V4, so left postero or left lateral pathway. Here, the step 1, V1 is negative. Then we go to 2, 3 AVF, which is positive. And once you see that this is positive, it becomes a right anterior pathway. And the transition is in V3. So it becomes a right anterolateral, anteroseptal pathway. So based on these, tachycardia ECG helps to differentiate AVNRT from AVRT. P waves and STT changes, if seen, can localize the pathway. Pre-excitation on sinus rhythm localizes the pathway, and localization of pathway helps while doing an EP study and RF ablation. Thank you for your patient listening.
Today here I am going to talk about relative risk and absolute risk. What is relative risk? Relative risk is the ratio of probability of an outcome in exposed group to the probability of an outcome in unexposed group. It shows the relationship between exposure and outcome. Relative risk is used in ecological data, cohort study, random clinical trial, adverse drug reaction, and intervention studies. It requires two binary variables. One is event occurred or not, and another is exposure group, exposed and unexposed group. How to interpret the relative risk? Relative risk greater than 1 indicates the increased risk in the exposure group in comparison to the unexposed group. Relative risk less than 1 indicates the exposure have less risk than the unexposed group. And relative risk is equal to 1 means both have same risk. How to calculate the relative risk? Here I have shown one table. Here predictor and outcome variable. Relative risk is equal to A upon A plus B upon C plus D. Let's take one example over here. Incidence in exposed group upon incidence in unexposed group. That is, I have taken an example of lung disease present and absent in the event group, and in the exposure group, smoker and non-smoker. So the incidence in the exposed group, that is 800 divided by 1000, so it is 0.8, and incidence in unexposed group, that is 40 divided by 2000, that is 0.02. Converting this decimal into the percentage, 80 by 2, that means 40%. It means that in the exposure group, there is a 40% risk of having a lung disease in comparison to the unexposed group. RR relative risk can become extremely large when the chances of an event in the unexposed group is low. Here I have taken one example that it is published by Vogel Chang et al. In 2050. His aim was to identify the mortality risk of infection in dialysis and kidney transplant patient. In his result, he found 82-fold higher with infection-related mortality in dialysis and kidney transplant patient in comparison to the general population, means unexposed group. And in his study, he found that women ages between 20 to 29 years, the mortality rate ratio was high as 565, meaning that the women in that age category who were treated with dialysis had a 565 times higher risk of dying from infection than women of same age in the general unexposed group. The number is tremendously high. That is due to the occurrence of the death from the infection that is very low in the general population, that is 0.01 per thousand patient per year in general population. Most of the time we use the relative risk in the meta-analysis study. There is one drawback that they do not give a true reflection of how much benefit the individual would derive from the intervention, as they cannot discriminate between small and large treatment effect. They usually tend to overestimate the benefit of intervention, and for that reason most of the drug company uses relative risk. This drawback can overcome by the absolute risk is that reflects the baseline risk better and that discriminate between small and large treatment groups. Now going to the absolute risk. Okay, what is absolute risk? Risk can be expressed in absolute terms by the absolute risk difference. It's also called attributable risk. Absolute risk is the number of people experiencing an event in relation to that population at risk. It is also individual risk of some event happening in that particular group. How to calculate absolute risk? That is absolute risk in the exposed group, that is positive event in the exposed group upon total number of cases in the exposed group, and absolute risk in unexposed group, that is same positive event in the unexposed group divided by total number of cases in the unexposed group. Formula to calculate absolute risk difference. Most of the time we shows the absolute risk difference attributable risk. That is subtracting the incidence risk among an unexposed group from the incidence risk among exposed group. That is A upon A plus B minus C upon C plus D. I have taken one example that shows you the difference between the relative risk and the absolute risk. In figure 1 and in figure 2, next slide, in both the figure there are 60 and 60 subjects are present in both the group. The black shows the outcome of interest and white shows the cases didn't have any outcome of interest. Here in the figure 1 there is a lesser number of outcome in comparison to the figure 2. Here the relative risk is 1.67, means 67% relative risk over here, and the cases are outcome is very low, and absolute risk over here is 2%, and it is showing a lesser outcome and the lesser absolute risk over here. In the figure 2 there is a outcome is higher, outcome of interest is higher in comparison to the group figure 1. Here the relative risk is same as in figure 1 and the absolute risk is 24%. So here as the outcome increases, the absolute risk increases and the relative risk is same in both figure 1 and figure 2. So the relative risk sometimes gives us an incomplete data, incomplete result in comparison to the absolute risk that gives us precise result. And that's why most of the drug company uses and shows us relative risk that so and so drug reduces the incidence by 50-60%. But if we count the absolute risk, if we analyze the absolute risk, then it shows the precise data. Thank you.
My session is on statistics test, odds ratio and hazard ratio. Odds ratio. Odds ratio is a measure of association which quantifies the relationship between an exposure and outcome from a comparative study. When we are doing comparative studies like case control study, we can see inside the table two groups, exposed and unexposed. For simple equation of odds, odds that a case was exposed upon odds that a control was exposed is equal to AD upon BC. Odds is a numeric expression of the strength of association between cause and effect when both expressions as categorical variable. A thumb rule for use odds ratio is both variables are categorical variables. The increase in risk associated with each odds depends on the rate of the outcome in the study. Odds show only correlation of two variables, not causation. It means when we can see the correlation between two variables, but we cannot found any cause between two variables. Odds ratio is a simple tool widely utilized in case control studies, clinical research, and meta-analysis. Calculations of odd can be done easily with the help of an online calculators and software like SPSS, Stata, and Metcalc. I can show you some calculations of odds. In example 1, in 100 births, the probability of delivering being a boy is 51% and being a girl is 49%. The odds of a delivery being boy is 51 upon 49 is equal to 1.04. This is our odds. Odds in simple equation, number of event occur upon non-event. And we can discuss example 2. This is clinical example for odds. In study examining the association between estrogen, this is exposure, and endometrial carcinoma, this is outcome. This calculations is shown in this table. According to the table above, individuals with endometrial cancer are 4.42 times more likely to be exposed to estrogen than those without endometrial carcinoma. Then interpretation of odds. Odds ratio is equal to 1. This indicates exposure does not affect odds of outcome. Odds is greater than 1. This indicates exposure associated with higher odds of outcome. If odds is less than 1, it indicates exposure associated with lower odds of outcome. Then we can discuss another test, hazard ratio. Hazard ratio are frequently used to estimate the event effect for time to event endpoints. A time to event analysis analyzes the time from the start of the study. For example, randomization in study to an event, for example, death. Hazard ratio allows a measure of association in outcome in survival curves. Main goal of hazard ratio, how one group changes relative to another. Hazard ratio represents the instantaneous event rate, which means the probability then an individual has survived to that particular point of time without experiencing any event. The hazard ratio is measure of risk. For example, in case of hazard ratio is 2, means the event will occur twice as often at each time point, give 1 unit, increase the second. Uses of hazard ratio in survival analysis to compare the risk of occurrence of an event of interest. For example, death in two groups, for example, treatment versus control group at a given time. Hazard ratio used in observational study, randomized clinical trials, and prospective cohort studies. Hazard ratio received from survival analysis like Kaplan-Meier, Cox regression, and log-rank text. It can be also calculated from statistical software. Now we can see interpretation of hazard ratio. Hazard ratio, if hazard ratio is equal to 1, means lack of association between two groups. If hazard ratio greater than 1, suggests group 2 are at increased hazard compared to group 1. If hazard ratio is less than 1, suggests group 2 are at decreased hazard compared to group 1, a smaller risk. Now this is curve of Kaplan-Meier curve. This show a time to event progression. Red light indicates treatment group and blue line indicates control group. When the decrease is in the graph, it shows end of the study. The time to event curve or Kaplan-Meier curve as time progress, percentage survival decrease in both groups. Plotting curves on the graphs allows statistical analysis to be performed to calculate the hazard for each group. Hazard model only determines whether the treatment are different or not, but do not indicate how much one treatment is better or worse than the other. This is called the limitation of hazard ratio. Dividing the hazard ratio and the control room produces the hazard ratio. One study performed by Clinical Journal of American Society of Nephrology, the title is AKI associated with higher risk of cardiovascular events 1 year after discharge? They take large number of cohorts patient matches with AKI and without AKI. After post-discharge, they take follow-up of, after 1 year, they take follow-up of these patients. After 1 year, they found primary outcome, heart failure, acute coronary syndrome, peripheral arterial disease, and ischemic stroke. These all are primary outcome. In 4 of them, hazard ratio of heart failure is 1.4. So we can conclude that AKI is independently associated with this event, especially heart failure after discharge. Thank you for listening me.
Hey, good evening, everyone. So today's this talk is about understanding basic statistics when we look at multiple trials. It's about net number to treat, as it is mentioned. This is an important topic because this goes on to tell you what is the efficacy of a therapy vis-a-vis, say, other therapies. Because this tells you what number of patients you need to treat to achieve one event reduction over what period of time. And hence you may have multiple trials coming in for multiple therapies, for multiple options, for multiple indications. But when you have to weigh out between the therapies to assess as to what was the care that resulted into what impact in the outcomes, you need to look at a number called net number to treat or number needed to treat. So this basically we'll discuss today in this talk. Basically, before I jump on to that, let me take you to two important concepts. One is IE and IU. IE is the probability of seeing no improvement after receiving the therapy. So this is the inverse of probability of seeing the improvement. So this measure applies only to a treated group. So when you have a treated group, you look at IE and you see if what would be the outcome not improving, the probability that you find on it. And IU is also referred as a probability of seeing no improvement after receiving the control therapy. And based on this, then you amplify and look at the net number to treat. So this measures applies only to control group, the IU, and the control group may receive a placebo treatment and or the standard care, as we know, on top of the existing new treatment. And this is what you get as the probability outcome in IU. So the meaning of net number to treat or number needed to treat is dependent whether the control group received a placebo treatment or an existing treatment, that is the standard care versus placebo care. And in case where placebo is given, the net number to treat is also affected by the quality of placebo. For example, sham procedures. As we know, in renal denervation therapy, when patients were taken inside cath lab and they were not delivered renal denervation therapy, but they had a sham procedure, a procedure patient who did not know they actually underwent a procedure or not, there was a good amount of reduction in the blood pressure in this renal denervation subgroup, despite actually not getting denervation therapy. It's just a sham procedure the patients were undergoing in the control group. So the type of placebo, for example, injectables versus oral therapies, would also have different outcomes in terms of the impact of the placebo. Now, these are some formulas that I thought I'll talk about before I jump on to number needed to treat. We all have a very simple table, and there will be some more talks that people will tell you about the odds ratio, etc. But I'm just going to summarize all of them in brief. You can see there are two groups. When we take a study, you'll have an experimental group and a control group. So let's assume that the experimental group or the therapy group, which has been receiving the new therapy, is of say 150 patients, while the control group is of 250 patients. Now assume that out of 150 patients, there are 15 events, say death, if you're looking at that as an important indicator. So say, assuming that there are 15 events in the experimental group, and out of 250 of the control group, the patients receiving only the placebo or the standard care, there are 100 events. Now this goes on to tell you the event rates. Now event rate would be just the ratio of the number of events out of total subjects. So in the experimental group, it will be 10%, while in control group, it is 40%. Or if you define it in decimals, it will be 0.1 and 0.4. Now, what is the absolute risk reduction? It is representing the difference between the two event rates. So we have 40% in control group event rate, 10% of in experimental group rate. So the difference between the two is 30%. So 40% in control, 10% in experimental. Hence, the absolute risk reduction is 30%. Now, relative risk reduction is the percentage change from the baseline. Now, if you look, compared to say 0.4, there is a reduction to 0.1 is about 75% reduction. So 75% reduction has taken place from 40% to 10%. And relative risk reduction looks though very huge, but absolute risk reduction is only 30%. Now, net number to treat is arrived at as by 1 upon absolute risk reduction. 1 upon absolute risk reduction. So then if that would be assessing as to how many patients do you treat to prevent one event. Now, absolute risk reduction is 30% reduction is achieved in every patient. So in how many patients you need to treat so that there is one event prevented. So one event is prevented. So if 1% is in every person, the risk reduces by 30%, it will become 1 or 100% when the number of patients needed to be treated is 1 upon absolute risk reduction, which is 1 upon 30%, and multiplied by 100, you will get it 3.33. So you need to treat 3.33 patients to reduce one event. Now, this is important to define as to what you're looking at. So risk ratio and odds ratio are different things. Risk ratio is again the ratio between the EER upon CER. So EER is the event rate in the experimental group, and CER is the control event rate, and then you divide the two is the risk ratio. So here you have 0.25. When odds ratio is, of course, AD by BC as we call it. So odds ratio is the EE by EN upon CE by CN, which is the events in experimental group upon events, non-events in experimental group divided by control events and the control non-events. And this odds ratio is here 0.67. So, and there is another factor called as preventable fraction among the AN exposed, which I am not talking today. So one of the examples I will try to give you so that you can understand how to comprehend this. Real life example, say, would be the ASCOT LLA trial. So this is the trial where the atorvastatin 10 milligrams was started in patients on hypertension, but no previous CV disease. So this trial ran for 3.3 years. And during this period, the primary event, which was defined as a new onset of MI, new onset of heart attack, not death, new heart attack was reduced by 36% in a relative risk. Now, what does it mean? Now, if you look at 36% overall risk reduction here, that this difference was, though relative, absolute difference between the two arms was not this much. It was the event rate of MI in the patients not receiving atorvastatin on Escort LLA trial was 2.67%. While in treatment arm, it was 1.65% in the patients who received atorvastatin and had hypertension. So the MI rate between the two groups over a period of 3.3 years, the difference was only 1.02%, which is nothing but the difference between the absolute risk between the two groups. That is 2.67 minus 1.65. So the absolute risk reduction is 1.02% over 3.3 years to prevent one MI, one myocardial infarction, one heart attack. So to get the net number to treat, you will divide 1 upon 1.02 multiplied by 100, which would turn out to be 98.04, almost 100, because 1%, right? So you need to treat 98.04 patients with atorvastatin, 10 milligrams for 3.3 years to prevent one heart attack in patients with hypertension with no history of previous CV disease. That is how you interpret Escort LLA trial. So every trial, when they come up with a number, you look at the number of patients. So you have to prescribe atorvastatin to a patient with hypertension but no CV disease for 3.3 years. Once you prescribe it to 98 patients, you will have prevented one myocardial infarction. That's how you interpret net number to treat. Thank you.
Friends, myself is Dr. Gaurav Singh. I am currently working as a AP in UN Mehta Hospital. Today I am going to talk about strain rate imaging, what it is and what are the clinical implications and clinical uses of strain rate imaging. It is basically a quantitative approach. It utilizes frame by frame tracking within a region of interest of small pattern of echo densities in grayscale B mode known as speckles. It has two important aspects of cardiac motion. One is magnitude and one is direction. Important terminologies. What is strain? It is basically deformation resulting from applied force. It is defined as a percentage change in length during myocardial contraction and relaxation. When shortening occurs, it happens as a negative in GLS and lengthening is positive. And what is strain rate? It is basically difference between two velocities normalized by distance between them. Then direction, it can be either longitudinal, circumferential, or radial strain. In longitudinal strain, shortening is termed as negative and lengthening is positive. In radial strain, thickening is positive and thinning is negative. In circumferential strain, shortening is negative and again lengthening is positive. Systolic, longitudinal, and circumferential strain normally has negative value, while radial has normal positive value. It can be either global or regional. In clinical practice, global longitudinal strain imaging is most commonly validated, hence most often utilized. This is again a display of GLS, that is typically termed as cord formation. This bull's eye, peak systolic strain of GLS minus 20. Again, lengthening is positive, shortening is negative. It is either plus 20 or minus 20 or in between values. What are the clinical applications? First one, most important, is coronary artery disease, either LAD, L6, RCA. Whenever they are deceased, we will get a decreased GLS. And decreased GLS post systolic shortening occurs before ischemia, and it is also a marker of viability. And another disease where strain rate imaging helps extensively is amyloid. Here we can see a typical echocardiographic picture of amyloidosis and longitudinal strain curve showing 2-chamber, 3-chamber, and 4-chamber view. And typical bullseye plot for cardiac amyloidosis. HCM is another disease where this stain rate imaging helps. It not only helps in diagnosis but also helps in prognostication and the treatment point of view, whether the patient needs AICD or not. In cancer, chemotherapy and radiation, patients who have underwent radiation therapy or chemotherapy, this stain rate imaging helps to predict LV dysfunction. In both these cases, we can get decreased GLS. Stress-induced cardiomyopathy. Stress-induced cardiomyopathy is another disease where this stain rate imaging helps in early detection of this disease. CRT, cardiac resynchronization therapy. The longitudinal strain and radial strain helpful in prediction of response to CRT. A longitudinal strain delay index of more than 25% predict response of CRT. Thank you, friends. I would like to end my talk by just summarizing what is stain rate imaging and its clinical uses. Basically, stain rate imaging helps in in CAD, HCM, sarcoidosis, and to predict the response of CRT. It is upcoming diagnostic procedure, and we will see more of stain rate imaging in future. Thank you.
Myself, Dr. Chirayu Vyas, and cardiac electrophysiologist and interventional cardiologist, just going to present a topic which is related to the use of 3D ablation mapping for ablation of cardiac arrhythmias, especially the tachyarrhythmias. The commonest form of fast heartbeats which with the patient usually arrives in the emergency room or maybe on an OPD visit occasionally, that is what is usually called as a supraventricular tachycardia. Would be like ventricular tachycardia, and the other tachyarrhythmias are also there, but most often they are the ones which present with this supraventricular tachycardia, which actually present as narrow QRS complex tachycardias with short or maybe intermediate RP intervals. That is what is a technologically correct term for a description of a supraventricular tachycardia. And the usual ECGs which appear in front of us are usually in the form of this, which is where the heartbeats range more than usually 150 beats per minute, maybe may go up to as high as 200 or maybe up to even more than that, 200 beats per minute. So for that, looking at the hemodynamic stability, usually they are treated with certain forms of intravenous medication boluses and very rarely with maybe DC cardioversion shocks. But actually the medicines are only a form of temporary cure for this kind of arrhythmias, because these are the arrhythmias which are usually caused by a re-entry of the electric current in an extra pathway which is located actually inside the patient's heart at certain locations. So a permanent cure of this form of abnormality is what is called as electrophysiology study and ablation, which is where looking at the electrical signals by introducing catheters, which are actually long tubes. This is what they're usually introduced from the groin area, the femoral artery and the femoral vein, and very rarely from the subclavian or the internal jugular vein. This is how they enter the heart's chambers and the different great vasculatures, including the vena cava and the other aorta and the other arteries. This is how actually these catheters enter these places, and these catheters are then connected to an electrophysiological system outside, which is where the signals which are appearing on that system, this is what would locate the extra pathway, which is what is causing the re-entry of the electric current inside the heart, which is the main mechanism by which this heartbeats go very, very fast. So that is what I showed on the ECG in terms of that supraventricular arrhythmia, which is the commonest form of supraventricular tachycardia, which is a AV nodal re-entrant tachycardia. That is what the ECG was, the prior ECG. So here is the cath lab demonstration of how we usually enter the groin area by just giving a local anesthesia, anesthetizing the skin, and usually entering through a needle by Seldinger technique and introducing the long tubes, the catheters, which are they called as, which is what ultimately arrive the heart and the great vasculature, gradually guided by the fluoroscopy screen, which is where this is basically the documentation of the intracardiac electrogram. We usually see the ECGs, which are usually placed, the needle, I mean the electrodes are usually placed outside the body. So this is what is demonstration of the electrical conduction system of the heart from outside. So if at all you want to have a detailed look at the electrical conduction system in a way, then that is the only way which is achieved by intracardiac evaluation of these electrograms, which is called as this electrophysiology study. Here is what in the picture you can see the ECG demonstrating the P and the QRS complexes, but actually the catheters which are placed through the femoral artery and vein into the heart chamber, this is where they're going into the high right atrium, the His bundle electrogram, and the right ventricle, which is where they're demonstrating the atrial electrogram A, the His bundle electrogram, the H, and V being the ventricular electrogram. So in detail, they're showing the electrical conduction system of the heart in terms of the parameters as to how they are measured, the baseline parameters, and as also those which would be revealed on stimulation protocols. So ultimately, these are the ways by which the heart is entered by these catheters, and the arrhythmia source of origin is localized as to what area of the heart, any focus or an extra pathway is causing these heartbeats to get going so fast. So this is what is the localization of the cause of arrhythmia, which is helped by this electrophysiology study. So actually, if at all we are going through the commonest arrhythmia as the first ECG showing the supraventricular tachycardia, the commonest one, the AV nodal re-entrant tachycardia. But actually, what's the fact in today's cardiac electrophysiological world? That most of the electrophysiologists would use the even higher version of mapping system, which is called as a 3D mapping system for very complex ablations, especially in tachyarrhythmias, which would be like atrial fibrillation, atypical right atrial flutter, a left atrial origin tachycardia, and especially the ventricular origin arrhythmias, the ventricular tachycardias. So especially these are the ones which would be done by most of these ablations would be performed correctly even without these 3D systems by experienced operators, but usually they would be preferred in 3D mapping systems. So these are the arrhythmias especially likely to be dealt with in a much better way by the 3D systems. So currently only 3 major systems are there in the market and widely used by the medical community. These are the ones in terms of their names. They would be a CARTO system as manufactured by the Cordis Webster, as it was known as earlier, and now it is called the Johnson & Johnson system. The Ensight Navix system, especially by St. Jude Medical, and the third one, the Rhythmia system by Boston Scientific. These are the systems which usually give us the 3D mapping technology for electrophysiology. So what are the advantages of a 3-dimensional electrophysiology mapping system? The 3-dimensional cardiac chamber anatomy, which is rendered by point-to-point acquisition of the spatial coordinates by moving the mapping catheter. The electrophysiology information would be acquired by fluoroscopy free catheter navigation. So without pressing on the pedal to ensure fluoroscopic evaluation of the movements of catheter, you can just move the catheter in a way to just outline the anatomy of the cardiac chambers. An activation map, which is where how the arrhythmia progresses, would be built with 3D mapping system. It could display local activation time for a cardiac chamber in relation to a reference electrogram, either early or being late. It is helpful to determine the tachycardia mechanism as either being a focal or a macro reentrant one. And this is how it identifies the ablation target size as to where to treat them correctly to give that a permanent cure. And thirdly being a location tagging function, especially of 3D mapping. This is what could mark the catheter in virtual space. It could designate the locations of critical structures, which is what would avoid the collateral damage, and catalog the ablation sites as to where you have already performed the ablation and allow return to these sites of interest if at all you want to return that again. The next would be a voltage mapping system, especially through the 3D mapping. It can display electrogram amplitudes throughout the cardiac chambers and guide the substrate ablation, especially in the absence of an arrhythmia, especially if the patient is in sinus rhythm, then just by a substrate based ablation based on this voltage mapping can just localize the source of origin of the arrhythmia, even if the patient is not in tachyarrhythmia. An isochronal color-based 3D system map would depict all the points with an activation time within a certain range with the same color, which can assist in visualizing the direction of wavefront propagation, as I told earlier, and indicates the local conduction velocities. And lastly, being the image merge function of a 3D mapping system. This is what would provide a detailed anatomical information, especially like a pouch in left atria, and facilitate the extensive ablation about these anatomical structures, including pulmonary veins, the left atria, and even a ventricular scar if at all we have entered the ventricles. But as these advantages of the 3D system, the commonly used and the frequently used the two-dimensional electrophysiology mapping system, what are the disadvantages? Which is what causes us to move towards the three-dimensional mapping system, especially in such kind of complex arrhythmias. An extensive fluoroscopic exposure to the patient as well as to the operator is the main reason of a 2D electrophysiologic mapping system, which is the main disadvantage. It has got a significant likelihood of collateral damage because there is lack of orientation of an anatomical plane where the arrhythmogenic substrate is, and also where the working electrophysiology catheter is doing its own work. There is all usually a presumption of points related to prior ablation work which is already done. So the ablation work desired, if at all, which needs to be done again, it also is only based on presumption of the fluoroscopic landmarks. An exhaustive list of ECG algorithms would be there in trying to localize a source of origin for the arrhythmogenic substrate, be it either a simple accessory pathway or maybe even a complex focal atrial tachycardia or maybe even a scar-related ventricular tachycardia. The ECG algorithms are absolutely exhaustive. So these are what the usual pictorial depictions of the 3D mapping systems. The commonest one being the CARTO, which is what is showing these color maps in a three-dimensional mapping system, as also in a Ensight Nevix, which is what is showing the same, the 3D mapping system, and the Rhythmia, the 3D mapping system. These are the pictures which are again localizing the arrhythmogenic substrate in a much better way. But as compared to these advantages which I've already described, we should always keep what are the disadvantages of utilizing a three-dimensional mapping system for a basic electrophysiology study and ablation. The first one being the cost of installing the system, especially in a working cardiology cath lab, is pretty much high as to that cannot be used usually by all routine cath labs. The cost of the patient that he needs to pay the cost for needing to undergo a three-dimensional mapping EP study and ablation, it is not getting done through maybe especially government beneficiary schemes as of now, especially like Ayushman Bharat Yojana or all, because of the cost of the mapping catheter itself, which is what is usually only a single time use. Very rarely would be used for 2 times in two different patients just to reduce the cost factor. But that is the usual burden which the operator as well as the patient would be constantly facing, especially to keep the cost under control. There's a steep learning curve for the operator as well as for the cardiac electrophysiology technicians also in terms of the 3D assessment of the mapping technology. Only few available technicians would overcome this steep learning curve for the 3D mapping in electrophysiology, and especially those who would be available on time to contribute during the working hours. That's very difficult in routine world today, day-to-day practice. Occupying the cath lab for a significant duration to set up the 3D EP system is one more disadvantage, especially because it takes a long time in getting it prepared, making other cardiology colleagues waiting for other procedures for a pretty long time, which is what is a practically pretty much a big disadvantage which everybody would be facing. Then A tachycardia should be sustained or especially most importantly tolerated enough to allow an activation mapping if at all we want to do that. The next disadvantage of a 3D system would be in case of a diseased atrium or a ventricle with extended scarring, either because of prior cardiac surgery or maybe because of any other reasons, comprehension of the activation mapping may be sometimes difficult. To date, cryoablation for atrial fibrillation does not combine with a 3D mapping system, which may render the cost of procedure excessively, and it is performed with fluoroscopy only. Symptomatic, most importantly, symptomatic recurrences of tachyarrhythmia are documented even after 3D EP study ablation, especially in atrial fibrillation or especially post-congenital heart disease surgery, left atrial tachycardias. Implantable cardioverter defibrillator device, ICD device implantation is often required even after a ventricular tachyarrhythmia getting ablated by a 3D mapping system for secondary prophylaxis of VT, which has got to have been installed, especially the ones which are associated with certain cardiac death prophylaxis. So 80% of the commonly encountered supraventricular tachycardia mechanism being atrioventricular nodal tachycardia, the first ECG that I showed, which is what in 99.99% of the cases could be safely and easily dealt with by ablation in conventional two-dimensional electrophysiology mapping systems. This is what we need to understand. So these are the basic pictures showing the two-dimensional EP study mapping systems ablating the AV nodal re-entrant tachycardia, the common SVT, as well as maybe even a left atrial accessory pathway, which is what would be transeptally or maybe encountered and then ablated accordingly. This is what was demonstrated in the third picture, especially in the presence of even a prior atrial septal defect occluded device, an ASD device in place, despite the AV nodal re-entrant tachycardia was ablated under 2D mapping system. The same thing maybe for the second picture, which is what are showing the surgical clips. That was a patient who had undergone a surgical open heart surgery, and despite that fact, was pretty much easily dealt with in a 2D electrophysiology system mapping. This is what would be a pretty much dangerous looking tachyarrhythmia, which is what most often people would recognize that as a ventricular tachycardia, and especially a polymorphic ventricular tachycardia, but actually it is a pre-excited atrial fibrillation, which is what would be pretty fast, would be pretty broad in terms of the QRS width and irregularity. This is what would usually identify this pre-excited atrial fibrillation, and once with a DC cardioversion, getting this rhythm to return to sinus rhythm would easily reveal a manifest accessory pathway, which is what would localize the site of the accessory pathway, which is what would be dealt with usually in a two-dimensional EP study system, very straightforward. So at the end of this discussion, which is what would be the real indications of three-dimensional EP study mapping system for ablation of tachyarrhythmia, it all depends on the benefit that is what would be achieved as to the cost which would be paid by the operator as well as the patient per se, in terms of these complex tachyarrhythmias, which would be usually dealt by these 3D systems in a much better way. Thank you so much.
Good evening, everyone. I am Dr. Gajendra Dubey. I am Associate Professor of Cardiology at UN Mehta Institute of Cardiology and Research Center. So today evening, I'll be briefly talking about 3D echocardiography. So 3D echocardiography is a latest addition to our imaging armamentarium. So concept of 3D has been in existence since the 70s, but the initial attempts to acquire 3D images were limited by the computing power of the imaging systems. However, the scenario changed in 90s and 2000s, and there was a remarkable improvement in imaging and computing systems. So this led to rapid development of 3D echocardiographic imaging. So during initial part, the imaging was not real time. They used to reconstruct it from multiple 2D images of heart acquired using multiple methods, and then they interpolated it to 3D imaging. However, real-time 3D imaging was first developed in mid-80s, and since then it has evolved rapidly to current state. So the transducers also have undergone massive changes. The earlier generation transducers were quite large with a big footprint, and it was quite uncomfortable to record images from these transducers, and the image quality was also not that great. the 2D image quality. However, the current generation transducers are pretty compact and they are almost similar to the transthoracic echo transducers, and the imaging quality is wonderful, both 3D as well as 2D. And with the latest generation of machines, simultaneous image acquisition, multiple plane acquisition simultaneously, and image recording 3D images in a single heartbeat is very much feasible, and the imaging is real time and it can be processed online as well as offline. So there are few basic 3D imaging modalities which are commonly used. The one is live 3D. It is used for live imaging and procedural guidance, say whenever you are doing some device closure like ESD device closure or some paravalvular leak closure. Then there is a 3D zoom mode. It is used to image a particular structure of interest, say mitral valve. If you want to look only at the mitral valve, then we use 3D zoom mode. Then there is a full volume acquirement, full volume mode. In this, we acquire the entire cardiac volume in the view. This is used for assessment of ejection fractions, volume, and mass of ventricle, atria, or other chambers of interest. Also, from this full volume, we can crop areas of interest and look at them in detail. And the fourth modality is the X-plane imaging. So it is basically a 2D imaging modality in which with just one view, you can get a perpendicular view to that particular view. Say if you are imaging in parasternal long axis, then you will get the short axis simultaneously without changing the probe position. And multiplanar reconstruction can be done from 3D images offline as well as online. So basic protocol or algorithm for 3D image acquisition is as demonstrated in this slide. First of all, we have to get a good 2D image. Good resolution 2D image is must for a good 3D image. So an optimal 2D image should be acquired by optimizing the gain, depth, focus settings, and then the acquisition modes should be selected. Modes which I have just told, that is either live or 3D zoom or full volume. And then it should be 3D rendered, which is done by the machine, and then it has to be displayed. So there are AHA guidelines for display also. Each and every structure should be displayed in a pre-specified manners. This has been made to bring a uniformity in display as well as reporting of 3D images. So what are the uses of 3D echocardiography? 3D echocardiography is very useful in assessment of LV ejection fraction and volume. So it gives us an objective assessment of EF and volume, and these volumes and EFs correlate very well even with the cardiac MR standards. Also the mitral valve anatomy, assessment of mitral stenosis as well as mitral regurgitation is it can be done very well with 3D imaging modality, and it offers details which are more useful than a 2D image. And then it can be used for guidance of transcatheter procedures like device closures for various congenital heart defects or paravalvular leak closures. Then it is very useful, according to my experience, it is most useful in the evaluation of prosthetic heart valves, as I'll show some examples later. Also evaluation of aortic valve prior to TAVI, and in evaluation of mass and volume of other cardiac chambers as well as dysynchrony assessment. So in these cases, 3D echocardiography is quite useful. So advantages of 3D over 2D, it is accurate and reproducible assessment of cardiac chambers. So there is no need for geometric assumptions about the shape while calculating ejection fractions and volume of cardiac chambers. And it gives a better understanding of structural relationship of various cardiac structures. Plus, it can give us intraprocedural live guidance of different cardiac transcatheter procedures. So I have so these are few examples which I have of 3D images and videos which I have acquired at my hospital. So this this video is showing on left hand side there is a 2D image of a prosthetic mitral valve with large paravalvular MR. So the same can be beautifully seen in this 3D video from the LA aspect. This is the surgeon's view. We can see the prosthetic heart valve ring has almost separated from the annulus, and there is a large area of dehiscence and with rocking movement of the prosthetic heart valve, as well as we can see few vegetations here also. So it provides us a great detail about the anatomy of the prosthetic heart valve as well as the dysfunction or the defect which is there. So this another video is of prosthetic heart valve thrombosis. So this is a 2D image which is showing restricted mobility of one leaflet, and this is the corresponding 3D image from left atrial aspect. So it shows that one leaflet is entirely immobile and it is stuck in closed position with some thrombus adherent to the leaflet. So this is another example of prosthetic heart valve thrombosis. This is a Sri Chitra valve which seems relatively well moving on 2D image, but the 3D image shows that mobility although is preserved, but there are multiple filamentous structures or thrombi which are attached on the left atrial side of this prosthetic heart valve. This is a great example of utility of 3D or advantage of 3D over 2D. This is aortic valve, prosthetic aortic valve. We are not able to see any thrombus or any gross deformity on this aortic valve in 2D image. However, the 3D image from the aortic side clearly shows that there is a significant amount of thrombus which is present on the leaflets of prosthetic aortic valve and hampering its mobility also. So this patient was thrombolized with streptokinase and subsequently her valve mobility normalized. So this is another example of pannus with paravalvular leak. So pannus is very difficult to image via 2D echocardiography, and it can be very well seen on 3D echocardiography. This patient had a prosthetic aortic valve with high gradients. The high gradients were persistent over a period of 6 to 8 months. So we did a 3D esophageal echocardiography on this patient, and this image, it shows pannus growth over the aortic valve arising from the ring of the aortic valve and leading to a narrowing of this orifice of the aortic valve. And simultaneously, we can also see a defect at around say between 1 o'clock to 4 o'clock. And in the corresponding color 3D image, we can see a leak, color leak also, which is arising from there. And this was a paravalvular leak which was arising from this. This patient underwent a redo surgery for removal of pannus as well as repair of the paravalvular leak. Native valves also, it is very useful. This is a case of rheumatic mitral stenosis. We can see the valve anatomy in great detail, and this 3D image is showing this restricted opening of the mitral valve as well as the two commissures, and plus there is this huge chunk of calcification which is present at the posteromedial commissure, and it is attached to the commissure also. So this detail is not seen in radiography, and it also helps us in selecting patients who are better suited for either BMV or mitral valve replacement or repair also. This is the LV aspect of the same valve, showing the classical fish mouth opening or appearance of a rheumatic mitral valve. This is another interesting rare congenital anomaly of a mitral blood cyst. On 2D echo, we can see an echo-free cystic type of structure attached to the mitral valve, and this is the corresponding 3D image which shows us the accurate exact site of attachment of the cyst as well as its shape, and it also shows that it is interfering with the coaptation of mitral valve leading to mitral regurgitation. So this is an example of the multiplanar reconstruction which I was talking about earlier. So this modality on 3D echocardiography gives us this freedom to accurately measure the area. Say if you want to measure the mitral valve area at the tip of mitral valves, which is frequently not possible with 2D imaging. So it can be very easily done in this 3D MPR. Radiologists are quite familiar with this multiplanar reconstruction, where we get 3 planes. That is, one is the imaging plane, the other one is orthogonal to it, and the third one is the short axis. This fourth one is the 3D volume. So we can accurately align the lines at the tip of mitral valve and get exact mitral valve area at its tip. So, and this is an example of LV function and volume assessment via using 3D echocardiography. So it is similar to the multiplanar reconstruction. We have to align the lines according to the endocardial border, and then it gives us accurate measurement of systolic and diastolic volumes as well as ejection fraction without any geometrical assumption about the shape of left ventricle. So these are few examples of congenital heart defects which I have imaged with 3D echocardiography. This is a large ESD, so it tells us about the shape as well as the largest dimension of ESD and its margins also. So it can help us in better selection of candidates for device closure. So this is the first one is a large ostium secundum ASD, and it is almost elliptical in shape. The second one is a small ASD with good margins all around. The third one is the left ventricle aspect of a post MI ventricular septal rupture. This patient underwent surgery, but this image beautifully shows us the size and shape of this defect. And with that, I would like to thank every one of you for your kind attention. Thank you.
Good evening, everybody, and I'll straight away go to the debate. Give me an extra minute if surgeons are not as good as speaking as cardiologists. We get our facts a little mixed up. Well, here we are trying to debate whether a 45 years old male with unstable angina and a left main lesion, what should be the course of treatment? And I don't think this is a matter of debate. I didn't want to debate it, but Kamal said, okay, let's debate. Hence, I'm here. CABG, according to me, is the only option for this. I would take you all back to pathology, and I'm sure that you all know the 4 stages of atherosclerosis. And you know that up till the stage of foam cell stage formation, you're not going to see that on the angiogram picture. It's only when finally the plaque progression occurs, there's degradation of extracellular matrix, and there's a rupture of the thrombus, you will be able to see something. Second, I'm sure all of you are aware that the coronary artery disease migrates from the proximal part of a vessel and smoothly moves distally. So usually the first few centimeters of all coronary arteries are affected in coronary artery disease. So the vast majority of plaque burden is found in the first few centimeters of any artery. We are talking of this Medina 110 lesion where, there is a left main lesion and there is an LAD lesion and the circ is normal. So I would like to ask all of you, do you think everything will be normal? If there's an LAD ostial lesion and left main ostial lesion, is there no atherosclerosis in the circumflex? It's not seen visually, but I'm sure there would be disease available, progressing in that circumflex also, which is not visually seen. It's in that sub-angiographic stage. I know you talk subclinical, but I'm sure there would be disease in sub-angiographic stage, which you cannot see. So maybe placing a stent from left main to LAD would cover the angiographically visible lesions, but it may not cover the lesion that is sub-angiography or not visible on an angiogram. And a normal ostium of the circumflex does not mean it is normal. There could be atherosclerosis slowly creeping into that ostium. So now if suppose Dr. Kamal is to do an angioplasty for Medina 110, is it simple? This is the flow chart of a Medina 110 angioplasty. You want to go from left main to LAD, then you want to do an IVUS into circumflex, you want to put an IVUS and OCT in LAD, and you're going to do all this complex picture, and you should an FFR of 0.8, and then you will be able to accept it. So imagine you would need IVUS, OCT, your experienced operators are going to be required, and then you're going to be able to plasty this. Look at this picture. This is how Medina 110 would look. Do you think there is no disease in circumflex? Would you call this a normal circumflex? On the either lips or the vessel, you have disease. So I even believe that there is nothing like a normal circumflex. So for a lesion like this in a young non-diabetic 45-year-old guy, when mammary is fantastic or internal mammary grafts will be fantastic, what is the problem? What would the survival be? I want all of you to take a guess. So let's see what are the results of coronary bypass surgery in left main coronary artery disease or in CABG in general. What are the results of CABG? I'm talking of 20-year-olds. So I've gone to old papers. So 67% at 20 years are asymptomatic after CABG, and at 10 years, nearly 70% of vein grafts. And this Gerard Laurie talked about vein grafts. 70% were patent at 10 years. Means such results. We have third study with 17.6 year survival, and patients completed nearly their life cycle after coronary bypass surgery. So this is the results of coronary bypass surgery. Look at angioplasty. I am just presenting some left main angioplasty results. Look at all these trials. This is Iris Main. Iris Main tried to compile the data of various studies, and they look at 1 month, 2 months, 3 months, 6 months, 1 year, 2 year, 3 year, and bare metal stent, and then they come to drug-eluting stents, and then they come to a second generation drug, and we talk of 1 to 2, 3 years. I am talking of 20 years. We have to talk of a patient who has to live for 30 years, not 10, 2, 3, 4 years. So these studies give some data, and everywhere they try to compare. TLR was better, TLR was more, mortality was less, mortality was more. At 3 years, are you talking at 45 years, you want to talk about 3 years? We're talking 3 years. Okay, let's look at main compare. That was a big study trying to compare left main disease angioplasty versus bypass. Okay, now what do you see in that? They tried to use bare metal stents, and at 3 years, they saw 82% need for target vessel revascularization. At 3 years, 82 means 18% needed revascularization. So extremely poor result as compared to CABG. Even when DES was used, the TLR rate was higher, target vessel revascularization rate was higher in PCI than CABG. So you've done it for CABG. You've done revascularization. That's what you need. You want to vascularize the patient, but that's the very procedure you're having to repeat at 3 years. We are talking of 30 years. Let me conclude. So left main compare said that the rate of target vessel revascularization is significantly lower in CABG group. And you're trying to say, okay, the rates of mortality and morbidity and stroke may compare with CABG. You're not saying they're better. This study did not say it is better. It just said that the results may compare. Then there was this huge Nobel trial. And this Nobel tried to compare what is what and whether CABG left main angioplasty is better or CABG is better. In that, let me tell you, the average age of patient was 66 years. We are talking of 45 years. And all these patients, I have not mentioned that slide, most of these patients had one memory artery graft at least. And everybody, a lot of them had the left main bifurcation stenting. So what are the results? Look at MACE. What is the rate of MACE for PCI? 28.9%. Mortality, higher in PCI. Non-procedural myocardial infarction, higher in PCI. Total repeat revascularization, higher in PCI. And stroke results, imagine stroke. You have more stroke than in PCI than in CABG, which is very surprising to me. And this is where a population of 66 years old was included. So what did Nobel conclude? Nobel concluded that CABG is superior to PCI, and repeat revascularization was higher after PCI compared to CABG, and everything else was similar, or PCI was not non-inferior. Not that PCI was superior in any one category compared to CABG. Then a study was done called Excel, and I'm just going to show you a comparison of what Excel was. Excel and Nobel trials were then compared. Now look at the red line that I made. It is said that revascularization, even Excel, was 12.9% in PCI compared to 7.6% in CABG. Also, death, MI, stroke was higher in PCI than in CABG. So we are talking about people dying, and we are talking about people needing repeat revascularization. So is that good? Then somebody else thought, okay, let me look at everything. Syndax, pre-combat, Excel, Nobel. And what did they conclude? They said that though PCI and CABG may have similar results in early years, they still have higher stroke rate. Imagine, higher stroke rate with PCI than CABG. Are we wanting patients to have a MI also and a stroke also? And again, they say there is a higher rate of revascularization. And this is not me. This is the cardiologists who compare all three trials, pre-combat, Excel, Nobel, whatever they could get on their fingers. And then again, Syntax trial said very clearly, only patients with less than 25 Syntax had any chance of anything being better than CABG. Otherwise, there was no way. If a patient had any extra lesion, then there was no purpose of trying to do CABG in patients with Syntax score. Imagine any patient having Syntax of more than 20, 22 should have CABG according to Syntax trial. And I don't think that's something that's well practiced. And again, PCI versus CABG, revascularization, repeat revascularization is very high. In Nobel, again they said, in Nobel, the MACE at 5 years, the MACE, death, and stroke rate was higher than CABG. So imagine, again, another meta-analysis and review all these studies. And they said that percutaneous coronary intervention in CABG, so comparative, just 2 minutes more, just few slides more. is similar. PCI is better for revascularization. So multiple trials, multiple studies show at 3 years and 5 years. We talk about 3 years and 5 years, and I'm talking of 20 and 30 years. Why does that happen? That happens because CABG is a procedure that works beyond any lesion. And it is said that there are many subclinical lesions that lead to MI. It is lesions that are less than 50% that are responsible for more MI than the lesions that are critical. And these lesions are not covered by CABG. This is what happens. The stent is placed here. There is a subclinical lesion beyond, and that is why you get an MI. Whereas what surgery does, it goes distal to all the disease in the coronary artery and puts a mammary artery bypass. Hence, the patients survive longer and do not have repeat myocardial infarction. So there is no PCI data that validates the requirement. Surgery provides a surgical collateralization beyond all disease coming in the proximal artery. Hence, it works. I will leave you this very, very small video clip, which I want you to see and digest. It's about a picture from Amitabh Bachchan. I'm sure you're aware of these lines, and I will leave you at this. Just listen to this.
आज मेरे पास आईवस है, रोटाप्लेटर, एंजियोग्राफी, एंजियोप्लास्टी, पेसमेकर है. क्या है तुम्हारे पास? मेरे पास माँ है, ली माँ.
Thank you very much, everybody, for your kind and patient hearing. But this is what surgeons have. We just have one Lima. Thank you very much.
Excellent talk by Dr. Anil Jain. I think he has given a big pass to Professor Kamal Sharma.
I didn't have much time. I could have talked a lot.
Yeah. Over to Dr. Kamal Sharma.
10 minutes.
Can I have my slides?
Please go ahead, Dr. Kamal.
So, yes, Dr. Anil Jain has given us a Ma, and I'll also give you another Ma. It's a matter of time. And he beat it around the bush. You know, he talked about circumflex, minor disease, major disease. Aapne nahi dekha, maine nahi dekha. Main andar jaake dekhunga, aap bahar se nahi dekhte. I'll show you what we see. So, next slide. So we are looking at a 45 male left main 110. Next slide, please. So this is what it looks like. Anil Bhai is not shown an angiography. He's not going to talk. He's going to talk about disease here, disease there. This is what it is. You can see absolutely clear circumflex here, and then I will show you the results. This is what Medina 11 is, and this is what we are talking. You have disease in the left main, and you have disease in the ostium of the LAD, but no disease in the circumflex, and we are debating it. I could have debated a much easier task, you know, ostial left main, shaft left main, but I thought I'll discuss something bigger. If I win this, I of course win that. Next slide. So when a patient, he said patients die. Who dies more? Let's see this. So there are two currently available STS risk calculator for an isolated CABG, which is available online, and you can Google and calculate it for yourself. For this case, same as for the PCI, there is another score. My patient dying for a PCI for a disease like this, risk is less than 0.8. What is risk in CABG? It is 1.4%. I know Anil Bhai might have much lesser, but it is surely much more than what a cardiologist averagely would give as compared to an average cardiothoracic surgeon, which is double the mortality you will have in PCI, in CABG as compared to PCI. And not even talking about renal failure, strokes, prolonged ventilation, scar, and that all we'll cover. Next slide. So that is the worst one reason. So you said higher mortality, absolutely wrong. You were talking about a combined 8 MACE point, which was driven by repeat need for revascularization. आपने 3 चीजों को combine किया, उसमें सबसे ज्यादा component repeat revas था, उसकी वजह से total बढ़ गया, आपने बोला mortality, but incorrect. Second, guidelines. All the 3 guidelines, go to next slide. All the 3 guidelines talk about, next slide. They talk if you have isolated left main or ostial midshaft, of course, that's class 1 in next slide. But even if you have to do 111, even then it's 1 in next slide. 110. So you have syntax score, fantastic. One thing I liked about his talk, he talks about as a surgeon syntax score, fantastic. What is the disease syntax score for this lesion? It is of course less than 22. Go ahead, next slide, which is again class 1A. You can go ahead and do the angioplasty for 110. 111, the syntax would be higher, 110 will not be. Next slide. So if you go to third, Excel trial, again, he was conveniently, taking out the things that he wanted to talk about. In Excel, the primary endpoint occurred was similar at 3 years. They were not higher. The only thing that was higher was need of repeat revas. If you ask a 45-year-old man,
that you're twice likely to die after my surgery, though it is only 1.5% compared to 0.8 with Dr. Kamal, and you're more likely 20% chances to get us and another angioplasty. What would he choose? I think answer everybody knows. Next slide. He may not mind a repeat revasc, but he will surely not get his chest open, which in the Shinto religion people believe that the soul escapes and man becomes soulless. Next slide. So you have again other trials like Nobel and pre-combat, which again Dr. Jain was selective, choosy to talk about. Of course, number of patients each of, but these were complete revasc. Next slide. These were non-STMIs and these were not isolated 110 Medina. And at 5 years, only thing that was all inclusive, all kinds of patients, triple vessel, only repeat revasc was higher, nothing else. So if this patient, even I assume that he has got very bad disease, which angiography also does not pick on the sarcostium, he may worse at the case, require a repeat revasc, but he's surely less likely to die. Next slide. Look at pre-combat again at 5 years, difference again was not statistically. So he said 15%, Hamara 17%. This is not statistically different. Even if I was to point out next slide, I can talk about higher MACE MI rates, which surgeons say, no, aapne to cheating kiya, MI ka definition badal diya in Excel trial. Because they said, no, biomarkers can rise up to 10 times after bypass, but angioplasty, if it rises 3 times, I will call it MI. You have different roles and different goals and different definitions to define MI, and still you lose the ground in Excel trial, and then you say, no, this is cheating. You define higher cutoffs for us, otherwise we'll not participate. Again, he mentioned 2 important trials, Iris Main and Main Compare. Again, he talked about the total trial. He talked about bare metal stents. I'm again talking about left main 110 subgroup. Next slide. And both of them clearly show that in these trials, the difference was not significant. Both of them had similar outcomes. If you look at mid-cap versus PCI-DS outcomes, the use of bare metal, there was relatively short follow-up, inconsistent use, and adjunctive medical therapies such as aggressive platelets. That's why you had CABG better outcome in these trials, not in when you use it compared with the drug-eluting stent. Next slide. Now, this is with mid-cap. I'm not even talking about, what about mid-cap surgery? People talk about, oh, chota hole karke kar denge surgery ke baad. Dr. Jain is a good surgeon, so he doesn't do that kind of a thing. But there are surgeons who beat around the bush saying, aapke itna bada chhed jo wo पैर में करते हैं वो छाती में उतना ही छोटा छेद करेंगे. But that is not how it works, because you have bigger incisional hernias, dehiscent seromas, and what is the incidence? 9% versus sternotomy, which is Dr. Jain is very good. He gets very lower exploration rates for that. But what about mid caps? Even they are more painful. Next slide. If you look at another reason, these are the references. I'm not talking out of the book. Next slide. And next slide. The Syntex trial, again, subgroup, if you go back, can you go back? If you can look at the Syntex trial, a 12-month rate of MACE was not different between PCI and CABG. Next slide. Amongst that, again, 35% were left main patients. Next slide. This is again outcomes you can see. So Syntex care here, what is Syntex score? It is 11. 11 Syntex, of course, he gets a PTC. Why should he get a CABG? Next slide. And what were the stents used? Texas. Texas is like, MiG-21, flying coffins, as they say. And now you have best stealth Rafales, which you can, can go and bombard anywhere, the top of the technology stents, which are much, much superior. Next slide. And that's the reason you look at the new generation stents, the struts are going, the polymers are bioabsorbable. The generation is much beyond of the drug. There is no drug left beyond some time. Next slide. And if you see the metal drug polymer triad, which is the debate which is already happening in the other hall, Dr. Jain might be listening to that because I'm not sure whether he's liking my talk or not. But that is another important aspect of the stents. Next slide. And yes, your ma. मेरे पास माँ है. कौन सा का माँ है? वो patient माँ patient. That माँ is with the patient. And that is Ma card, not the Bima, Lima. It is Ma of Ma card, where the angioplasty is also free. Dr. Jain is, probably not available in Ma card. Next slide. So that Ma card actually brings down the cost. It's done for free. And he gets a stent for free. And he doesn't have to pay anything for that, getting his chest open. What is the duration of hospitalization? 24, 48 hours. He may get another revasc at the rate of whatever we discussed. Maybe 5 years, 10 years, or 20 years. And left main, for the CABG, he'll be in hospital for 5-7 days. For a poor guy who is having Ma, the Ma card Ma, is not going to earn for his own Ma at home to feed her Ma. So for that Ma, the government has given one Ma, and that Ma is better than your Lima. Next slide. So this is the scar. How is he going to earn and feed his Ma? Next slide. What is the anesthesia? This tube, you explain the surgeon to the patient, you will put a tube under your throat. He'll say, no, sir, if you can do something with just giving an injection and my arm radials, he's good enough. Next slide. What about imaging? He said, the more plaques I can see. Dr. Jain, I don't know, how do you see? Because the plaques are inside the coronaries. So you are actually doing palpography. You're just palpating the coronaries from outside. You're relying on the angiography, which may actually not pick up. But I can see because I can image. I can go inside and see where the plaque starts, where it ends, whether it's calcified, stage 1, stage 2, stage 3, 4, which Dr. Jain very well said. Imaging is in my hand. The day surgeons will start doing imaging while doing Lima, I will start arguing in favor of Dr. Anil Jain. Next slide. And of course, why hunt the mountain for a small mole? Chota sa lesion hai, kyun saap chhati chirte ho? Next slide. And what happens for that angiogram? This is a case which was published nowhere else but in India only. Anush Gupta in European Heart Journal published. Aapne bola sir pinch ho jayegi, dekho B mein ho gayi. He did an FFR and did a check angiogram at 6 months. And you can see the spasm or the plaque shift had not resulted in any ischemia and the artery was still patent. Thank you very much. Next slide. Thank you. Thank you very much. Thank you.
I think this was a debate between really two bulls, both expert in their own fields. And I agree, Ma and Ma both are important things. But see, I would consider in this patient, Anil, in this patient has non-dominant circ, non-diabetes and very young age. So I would also personally go in favor with what Kamal Sharma has said. But had it been for 65-year-old, diabetic, dominant circ and significant lesion in circ, I would definitely go with the Anil Jain. So fortunately, I have both the options. Now I'll ask another thing, Anil, you said disease progress from proximal to distal. But we have seen that once you do surgery, the disease progress proximally as well. I've seen many patients with 60-70% block in proximal area. You put Lima and proximal lesion becomes 100%. So the nature provides disease from proximal to distal. Surgeon reverses it from distal to proximal. This is just my observation. Now I'll ask Dr. Mridul Sharma to go ahead and give his comments.
Virendra, give me a chance. Huh?
The problem is that we do not have surgeons.
I'm the only surgeon, but I'll hold the fort. Don't worry.
Yes.
The problem is we do not have surgeons as capable as Dr. Anil Jain is in majority of the centers in Gujarat. So majority of them undergo angioplasty and encouraged by the results over many years. We have now started doing left main angioplasty in very complex situations also. And the results have been gratifying, not only clinically, but even angiographically. You see 1 year, 2 year, 5 year down the line, you're pleasantly surprised to see well-flowing stents. So all depends on how good you are at performing such complex angioplasties.
Of course, I would like
See,
to
for a good Lima, you will require Anil Jain, but for left main angioplasty, any Kamal Sharma, any Tom Dick Harry can do the left main to LAD and it will work. So excuse me for saying that.
Yeah, technology has spread much faster amongst the cardiology community. The surgeons, we are seeing many surgeons, surgical patients, they are coming back in 6 months, 1 year with closed grafts.
The only thing, Kamal, how would you explain if you have to do angioplasty for left main in my Yojana, you will not be using IVUS or any of the things, and you will use only particular type of stent, and may not be, they will not use the costly medicines, and stent thrombus is a real issue, and patient can die suddenly, and we often don't know this type of risk.
So good question. Good question.
My question, Virendra, that was my question. You stole my question. I have got some other question.
So good. I have to answer only one question. That's good. So see, prasugrel in generic is as cheap as clopidogrel twice a day. So don't even think about that. He's not going to be on drugs. Number one. Number two, imaging. There are enough data to now compare CT to compare stent boost with IVUS, which shows it as non-inferior, which every now cath lab has. So you can do a stent boost, especially when you're doing a left main to LAD and you're not doing a crew bifurcation. Probably imaging may not be compulsory, but you would always encourage it to do. Again, third thing, at institute, we do imaging in left main bifurcations, even in Yojana. So it's a misnomer to assume. And I didn't say I'm going to operate at Sal. I can operate this patient at UN Mehta. What's the problem with that? I'll go and operate at UN Mehta. I'll do imaging even in my Yojana, no problem. It can be done. Prasugrel can be given. Even Ticagrelor is given in Yojana at UN Mehta. And in private also, Prasugrel, all of the cardiologists are using in Yojana with a generic Prasugrel. What's wrong with that? And so if you have Prasugrel, which is now shown to be more potent than Ticagrelor in antiplatelet. Sorry?
The need of imaging is only in very few selected patients. We are not doing it in majority.
Absolutely. When you're doing left-hand bifurcation, you're doing ISR, then probably yes. Otherwise,
globally, less than 5% of individuals globally who are undergoing angioplasty undergo any intravascular imaging.
But I agree.
Probably overhyped technology. We talk in conferences,
but stent ka bhav kam ho gaya, imaging ka baat chalu ho gaya.
Practically, we don't do.
But okay, I guess I should get my couple of minutes after you discuss options of angioplasty and stuff like that. See, couple of points I really want to make up. They say early mortality CABG 1.4%. That's according to the scores, but actually a young patient would be low for renal failure, low for stroke, low for everything, and he usually does well. But we are talking of 30 years. What happens over the next 30 years to him? Not early mortality and long-term mortality. Look at all the trials, I read a lot even before this particular debate. They have mentioned very frequently that there is need for revascularization beyond the stent, not the stent. The stent may work. It is not the problem of the stent. Again, that's what I want to pressurize with all of you. The problem is disease. Disease usually progresses in the first few centimeters of any artery. It may keep progressing from LAD ostium downwards, circ ostium downwards, and that is not something you or I can prevent. That's a normal aging process, normal way the pathology works.
Okay, so my question for that would be...
Kamal, it's my 2 minutes. Please.
Go ahead.
So that's something you can prevent. What happens with using a mammary artery graft, and that is why mammaries have shown better long-term result, is mammary goes beyond the few first centimeters of the vessel, and it tries to bypass even areas that in future disease can develop, and it's like a form of surgical collateralization. There is this lovely paper from Donest in 2019 that was in JACC. I can send you the link, where all your major cardiologists were, and they mentioned that. So the mammaries go beyond. Second, the mammaries themselves secrete nitric oxide, prostaglandin, other things which prevent progression of disease. Hence, we have 15 years patency rates of mammary artery. I'm sure you all have done plenty of angios of mammary arteries that are flowing. Anything may close, but the mammaries work. And nowadays, surgeons are getting better at bilateral mammaries. Again, you say anyone can do a left main angioplasty. Do you think a 99% left main and some person sitting with a cath lab all alone in a remote area is going to have the guts to put a stent there in case the patient crashes, IBP, this, that, blah, blah.
They are doing.
Third, I know they are doing. Third, the problem of imaging. If you want to do the ideal thing, like all the results have shown, now you say, okay, we can do this type of imaging, that, see, some imaging in circ is required. And let me tell you, circ MIs are bad. Whenever the circ closes and there is an MI, these lead to mitral regurgitations, problems, aneurysms, heart failure. These would happen. And we are talking of a 45-year-old patient. And there is no clinical data. I searched the entire net beyond 5-7 years for such disease. CABG, 20 years, 30 years, easily. And we are talking, if it was Kamal had said 65 years, a 70-year-old guy, I would not have debated. I would have said, I want to be a ranchod. I am going. I think a plasty is good. You all do plasty and get away. But you are talking about a 45-year person. And in India, they can't afford. Ma is okay. Ma Rivasana is okay. But if you want to do a good job in a private sector hospital, patients can't keep affording coming back. Oh, sir, mera stent wapas band ho gaya, extend circumflex mein. It is closed. One more stent in LAD. A mammary artery graft, a bilateral mammary, and I've seen my patients live 20 years. Yesterday, I got a call from a patient I operated in 99, and he died a day ago, and the son calls me and says, you had predicted 20-year survival. He lived 20 years and he just died. So there have been, and you know, there is ample data of CABG and especially Lima alone pulling a patient off for 20 years. So I really believe it's a good strategy. Maybe stents over time will develop. You will need more advanced stents, better technology. Someday you will get there. But as of date now, For a 45-year guy, if I don't want him to risk his life, I would do a CABG. That's it. Thank you very much. I know. And one more point which I wanted to point about antiplatelets. Now, just now I was hearing your debate. There can be bleeding. We can use dual. We can use single. We can use prasugrel. We can use ticagrelor. So your debates even on antiplatelets are not over. Where is the question? Where is with simple CABG, a simple aspirin, even if he stops, these lemas keep flowing. So your debates on antiplatelet is not over. Where is the question of angioplasty to left main, circumflex, complex? And I don't know how much antiplatelet the guy will have to eat. He'll get a couple of ulcers in 30 years. He'll get bleeding piles. He'll get something else and he'll get into trouble with a CV otherwise. So it's not that I'm against it. The procedure is excellent. Technology is progressing. But I still think for a 45-year-old guy, I think CABG is the better guy. Thank you.
See, Anil, I have one question to you. Whenever you put lima to LAD in this type of situation, the LAD disease progresses. And many times LAD get occluded. Now patient is left main going to the circ and there is a tight lesion in left main. So what will happen to circ in that situation? And that
in this situation, I would have grafted the circ.
That way.
I would have done a bilateral memory, lima to LAD and lima to OM. When we do a left main, we always put a graft to OM. There is no doubt. And that you talk to proximal, it is not because of lima the proximal. That is the disease.
Will you graft an RCA which is 50% also in this patient? Suppose he has a 30% lesion on RCA. Will you graft? No, you will not graft that, but you will graft a circumflex. Even if it does not have a disease, how does it justify?
50%. In fact, I'm going to do a case on Monday where the patient had an angioplasty, similar angioplasty. His LAD is now 99%. His RCA stent is flowing, and we are wondering now what to do. He had a left main to LAD plasty. I don't bring the film here, but the LAD ostium is now 99%. So it's the disease progresses proximally. That is why you see only the distal lima flowing. The proximal disease is bound to progress. Come what may, it progresses right in all angiograms.
Disease progresses even more rapidly in the native artery when you graft a not so critical disease. That also we know. If you graft a 30% RCA, then either RCA will close or the graft will close. That everybody knows because competitive flow is not going to flow. So circumflex is anyway a placebo that you're protein. Your only thing that why you're doing it is doing it for lima.
Then I have come on to plastic. Don't worry. You are there, yeah, and you're dual antiplatelet. They will win the day.
Just one request to Kamal: don't do plasty for left main in my yojana because I have seen patient who goes for my yojana angiography, angioplasty. When it gives surgery, 7 days stay, they go to the deluxe room. So these are the people there. Originally would get patient in deluxe room. Don't do it in my yojana.
It's true. They get angio in Ma and they come CABG in deluxe room. I'll show you these angios. There was a patient from Anand. And I don't want to name the cardiologist. He was in a good hospital in Zydus Hospital at Anand, and his son was in Ireland, and unstable angina. He got angio in Ma. His son flew in from Ireland, and they had a CABG in a deluxe room in Epic.
So yes, sir, I'm here only. I'm just listening.
Yeah, you're there. You know about that patient. So that's what happens.
We'll have to close the session. We are already short of time.
Hello, everyone. This is Dr. Komal Shah, and today we'll be discussing the concept of sample size. So there's a case where first-year resident wants to calculate the sample size for his thesis, where he wants to assess the utility of IV US-assisted PCI as compared to those undergoing without that imaging technology. Then how should we calculate the sample size for this kind of cases? So first of all, it is critical to understand the study design and methodology that we want to opt for addressing this research question. So the students is having this kind of study design, which is displayed over here for his particular study. So it is a randomized controlled parallel trial where 2 study groups will be included. First would be the intervention arm, where IUVS guided PCI technology will be used. And second one would be the control technology, where conventional angiography guided PCI will be used. Now we need to be really specific about the outcome that we want to assess for this particular research study. So over here, the student want to assess the outcome in terms of target vessel failure at 12 months. So this has been critically described further in 3 indicators where cardiac death, MI, or target vessel revascularization are considered. So with this basic information about the research design or a study design, we need to understand the concepts of sample size. So number of subjects or the participants that need to be included in the study, that is by and large known as sample size. It is one of the most critical concepts and aspects of the study design, especially if we are going ahead with an RCT, that is randomized controlled trial, which is needed for accurate inference of the findings that we are getting. If we are having incorrect sample size, it means that we might end up having misleading results. By and large, there is no magic formula. The sample size calculation varies from type of study and the study design that we are choosing. So it is not one size that can fit all the study designs. So for this particular study, we will be discussing what could be the minimum requirements that we need to have. So the sample size can be calculated by various methodology. Classically, there are equations available which can be used manually, and the data can be entered in those equations and you can get your sample size. Apart from that, nowadays, there are various software which are available, which are free also, and which are purchasable software also. Based on need of the individual and the study, we can purchase or use the free software. But before we go ahead with any of this tool, we need to understand that what would be the minimum information that is needed to calculate the sample size. So over here, I have tried to list down those information which are needed prior we go ahead with the sample size calculation. So first of all, we should be ready with the confidence interval. Confidence interval is generally considered or taken up at 95%, but you may vary it based on your study design. So for this particular study, 95% of the confidence interval was taken up by the student. Then power of the study. How much confidence or power I want to impart to my study. That should be a minimum limit for this kind of study. Then ratio of cases to control or exposed to unexposed. So how many individuals I'm planning to take up or enrolled in my intervention arm, as well as how many I want to enroll in my control or unexposed arm. That particular ratio should be very clear in my mind. Then something which will be needed before I go ahead with the sample size calculation. Now there will be a question in your mind, then how do we obtain this information? The 4 or 5 factors that I mentioned in the previous slide. So for that, there are various ways. The first and very popular way, you go through the prior published literature and identify what is the odds, how the controlled people were enrolled, how the cases were enrolled, what were their criteria, and what were their findings. So the most common and very popular way is to rely on the prior published literature. The second one, if nothing is published in that area, you should go ahead with the expert opinion. People who are already working in that area, you can ask them about the expected outcome. What could be the outcome of interest when you are taking care of this kind of study? Then if that is also not available, you need to go ahead with the primary study. You yourself need to run a pilot study to understand and measure your outcome of interest, and then you can design one large study. So we have the citation as well as the study details over here, which I have referred for the sample size calculation. Yeah. So this is about the type of information that I have extracted from that particular study. I was interested in the total number of participants in each group. So the study that I have retrieved from the literature, it has taken up 724 individuals in both the arm, in my intervention as well as my control arm. Now, the next question or the next information that I require is my outcome of interest. What was the impact of PCI that was guided through IVUS as well as angiography on the outcome. So over here, my primary outcome was target vessel failure at 12 months, exactly the same that I'm planning to take up. So I was fortunate to get this article, and I need to dig out the result from this particular article, which I'll be using for my sample size calculation. So they found out that in 2.9% of the individuals in my intervention arm, these events occur, in contrast to 5.4, which I'll be needing and using for my sample size calculation. Okay, so now moving ahead, what are we supposed to do with this information? So this is one very commonly used software, user-friendly and freely available software for sample size calculation, that is known as OpenRP, that I have used over here. As you can see, the circle which is marked over here, that area gives you information about sample size calculation. So moving further, when you click the sample size, you will be provided the option whether you want to go ahead with the proportion, unmatched case control, cohort or RCT, and mean difference. So over here, my study requires a sample size calculation for an RCT. So when I click that particular area, this kind of window will be opened. And as you can see, all the information that I have extracted from my previous article are mentioned over here. So that information I need to add in this software. The first section is about the confidence interval. We need to mention that which would be the minimum confidence interval that we'll be taking up in a two-sided manner. So over here, statistically, generally 95% of the confidence interval is the most effective and accepted threshold. Then what would be my power of study? So minimum power of the study for this kind of studies are selected as 80%. So this is what I'm selecting. Then ratio of unexposed to exposed in this sample. I want to run an RCT where both the arms will have similar number of patients or participants. So I'll be putting my ratio as 1. I can change it as per my need also, 1:2 or any other ratio. But for this study, I will be needing 1. Then percentage of unexposed with the outcome and percentage of exposed with the outcome, odds ratio, and rest of the other information. Now, this information I have collected from my previously published article. So when I add this information in this particular software, it will be looking like this. The window will be like this. So 5.4% was my incidence of that event in my control arm. So that is the information I need to add in the percentage of unexposed with the outcome. Whereas the contradictory information that is related to my intervention, that needs to be added in the percentage to information in the software. The software will be calculating the odds ratio, prevalence, and rest of the things by its own. So I don't need to add that particular thing. I just need to click the calculate button, and you can see at the right-hand side, the sample size is calculated. So this is the sample size that I will be needing for this particular study. And generally it gives you through 2-3 techniques or 2-3 methods. So generally we take up something which is coming as the highest one. So over here, I can go ahead with 2-1-2-2. Now, there are certain issues with this kind of sample size calculation whenever you are going ahead with even with software or manual calculation, because it heavily depends on the published literature that you are using and your study design. So at times, there are possibilities that over here, my primary outcome was only 1. But there are chances that for some kind of study, I might have more than 1 primary outcome. And there are cases that the primary outcome related information are quite contradictory in the published literature. So I might not have 2.9 and 5.6 as the only percentage which is available. So I might need to calculate the sample size for many other percentage or other outcome related finding also. So in that case, there is always a way out. You need to calculate the sample size for all of this outcome in all the situation. Even your primary outcome has got 2 indicators. You need to calculate the sample size for all of them and take up the sample size which is highest. So highest sample size, when you are choosing, it gives you an assurance that all of your significance outcome will be covered with that sample size. So this is how you go ahead with that sample size calculation when you have multiple outcomes to consider. These are some of the resources that I've referred over here. I have given references for manual calculation of the sample size, as well as I've given you the links for size calculations. The softwares are also accompanied by the tutorials, which are very easy to understand. And this is my contact detail. In case of any query, you can refer and contact me through this detail. Thank you very much.
Today, I would like to talk about CTO procedures for beginners. I hope this lecture will help for beginners. I have nothing to disclose. Recently, CTO procedures success ratio is improving. Retrograde approach dramatically improved the CTO success ratio. Before starting retrograde approach, we must familiarize antegrade approach because CTO procedure require various skills and knowledges, especially for retrograde approach. During retrograde approach for externalization, you must advance the wire antegradely. It means antegrade preparation is necessary for retrograde approach. So we must familiarize antegrade approach technique. Before starting CTO procedures, you should estimate success rate. This is JCTO score. Maybe you know. We can estimate success rate using this score. High score case is a difficult case and frequently requires retrograde approach. JCTO score over 3 is very, very difficult. CTO vessel is straight. CTO entry is tapered. Around the CTO entry without side branch, and inside of a CTO body without severe calcification. CTO length is short and the CTO exit is large. Like this case is easy case. On the other hand, CTO vessel is tortuous. CTO entry is abrupt. CTO entry with a side branch. Inside of CTO exit, inside of CTO body is severe calcification, and the CTO length is long, and the CTO exit is small. Like this case is tough case. Like this case, sometimes we need retrograde approach. For intensive wire control, for antegrade approach, intensive wire control is necessary, and we need enough backup and coaxiality. For CTO procedures, guiding catheter stabilization is very important. For intensive wire control, stabilization is very, very important. Method of stabilizing guiding catheter is using bigger size guiding. It's very simple. And the backup type guiding catheter. Sometimes deep engage and power position is useful. And the mother-child guiding technique is another method. Techniques of stabilizing guiding catheter is like this. Anchor wire technique. It's very simple. Only insert another wire into the side branch, and the body wire technique, and the anchor balloon technique. This is a very famous technique. Sorry, my slide is long. And the coaxial anchor balloon technique. Using OTW balloon like this. This is RCCTO case. We can see microchannel inside of CTO. You can see. You know, about 50% of CTO cases are not totally occluded histologically. They have microchannel. When you can see microchannel inside of CTO, you should create tiny curve like this one. Filter XT series, filter series, and Schoenbrock can create tiny curve like this. Other wire, it's a little bit difficult to create like this tiny curve. This is another case. Sorry, this case cannot move this case. Why? I don't know. I'm sorry. And like this case, I couldn't use a backup guiding catheter for this case. So it means I use the Jadkins light guiding catheter, but I want to stabilize the guiding. So I insert the wire to the side branch and performing the anchor balloon technique. Fortunately, I could cross the wire using only XTR, and this is the final angio. This is another case, also RCCTO case, but this RCA has big problem, abnormal origin. You can see. Like this case, stabilizing guiding catheter is really difficult. Finally, I used guiding extension devices for stabilizing guiding catheter because I wanted to control the wire intensively. You can see guide extension and a corsair insert in this. I couldn't cross, even though using XTR and Gaia first. So I decided to change the wire to Gaia second. Finally, I could cross using Gaia second like this. This case, I could succeed integrally because I could control the wire intensively with corsair and guide extension devices. When you start wiring, firstly, single wire manipulation, and secondly, parallel wire technique. And sometimes we need IBUS guided wiring. I want to talk about handling the wire. You should feel of wire tip resistance in CTO region during push and occasionally pull back to keep the true lumen, not to go into the false lumen, and to change the wire appropriately. It's very important point. And very important point is never advance fast and rotated roughly. This is also RCA-CTO case. I tried to cross using XTR with anchor wire technique. But I couldn't cross here easily using XTR. So I quickly changed the wire to Gaia fast. After changing the wire, I could cross easily to the distal true lumen like this. I want to talk about single wire manipulation. If the CTO entry tapered type and you can see microchannel inside of the CTO body, you should choose XTR wire. Some doctors want to use XTA, but I firstly recommended XTR because XTR tip load is only 0.6. It's safe. We not to create subintimal space easily. And CTO entry, tapered type, and without microchannel. You should choose XTA or Gaia fast. Because maybe you need a little bit tip load of the wire. And the CTO entry abrupt type depend on CTO lesion classification. If you know vessel course, if you cannot know vessel course and the CTO exit small or ambiguous, you should choose Miracle series or Ultimate Bro 3. Because this wire low rate of perforation compared to other CTO wires. If you know vessel course, for example, from CT angiography or something, and the CTO exit large or clear, you should choose penetration and controllable wire. It means Gaia series or Conquest series. If you cannot cross the distal to lumen using the fast wire, you should switch to parallel wire technique as soon as possible to avoid create dissection and hematoma. Keeping controls of fast wire sometimes create the big hematoma, and finally, we have some risk of losing distal to lumen. So if you want to perform parallel wire technique, you should switch to parallel wire technique as soon as possible. And using the dual lumen catheter, Crusade or Sasuke is very useful. My recommend is Sasuke because Sasuke's side hole is a little bit go to antigradely compared to Crusade catheter. And this is also RCA-CTO case. I could not see microchannel inside of the CTO. I started using XCR, even though we cannot see microchannel. But I wanted to try one time using XTR, but I could not cross easily. So I changed the wire to the Gaia fast. After changing Gaia fast, I thought I could cross the CTO lesion like this. Wire movement, it was very smoothly, like this. But from the angiographically, I found that my wire went to subintimal space. And sorry. So I performed wire technique using Gaia second. After changing the wire to Gaia second, I could change the wire direction intensively like this. And I could change the CTO entry like this. And finally, I could cross to true lumen using Gaia second like this. Then this is the final angiogram. I could succeed. Finally, I want to talk about IBUS guide wiring. For IBUS guide wiring, dilatation of subintimal space is required to deliver IBUS catheter. Sometimes 8 French guiding catheter is required for simultaneous wiring with IBUS. Stiff wires such as Conquest and Gaia second or third are required. This is already CTO case. I could not see microchannel inside of the CTO region. Here. I used Gaia firstly, but I felt some resistance around the distal LED. So I checked IBUS and I found Gaia fast inside a false lumen from maybe from around here. Around here. I performed the wire technique using Gaia second with Crusade catheter. I want to stop one time. This is a collateral from the RCA. My Gaia fast already into the subintimal space. Firstly, I checked the IBUS and from the angiographically around here, my wire went to the subintimal space. So I insert the double lumen catheter here. And from here, I use the Gaia second. This is because I use the 7 French guiding catheter. If I use the 8 French guiding catheter, I performed simultaneous IBUS guided wiring, but this is the 7 French guiding. But performing the wire technique using Gaia second, fortunately, I could cross to the distal true lumen. This is the IBUS imaging after crossing the true lumen, but already you can see create the subintimal, big subintimal space on here, like this. So finally, I needed the long stenting from the distal LED. Integrated approach is still a major modality for CTO PCI, and we should estimate the difficulties region morphology. We should use various kinds of integrated techniques before creating dissection and hematoma to distal through lumen. CTO operators must know various kinds of techniques and knowledge about CTO. CTO operators must know characteristics of wire and microcatheters. Thank you so much for your kind attention.
Hi, good evening, everyone. So today's talk is the vignette on vagal nerve stimulation therapy, and this is a new emerging therapy that we are looking at. Uh, uh, the This is how the X-rays you may actually end up encountering. A patient may have an ICD, and there is another lead which you can see on the opposite side, and the lead is actually tunneled through into the neck on the vagus nerve, and this is what is a vagal nerve stimulation therapy, or baroreceptor autoregulation therapy as it is known, and it is one of the recently approved therapy by US FDA in refractory heart failure. So this all started with the multiple trials. We now have a lot of data emerging for it, but the first in our part of the world was part of the Anthem study, and this is the publication that happened when I was author and lead investigator from my center, and this was published in JACC. I was fortunate enough to do the world's first vagal nerve stimulation device implant in a refractory heart failure, and now we have recently published even 7 years follow-up and a long-term follow-up from the Anthem and Core study. Basically, this study was to look at the improvement of LV function and heart failure symptoms, and the objective was to evaluate whether autonomic regulation therapy, also previously called as ART, with the left or the right side for the treatment of chronic symptomatic heart failure with reduced ejection fraction. Firstly, it was looking at its feasibility and tolerability. Secondly, at the primary endpoint, which was the incidence of procedure device related AEs at 9 months initially, and then it was followed up into ENCORE extension and ENCORE studies, which also looked at into the long-term follow-up up to even now 7 years follow-up. And they also assessed the efficacy outcomes in terms of LV ventricular ejection fraction and end systolic volumes at 6 months. They also looked at the overall in the study into the LV end diastolic diameters, quality life as assessed by 6-minute walk distance, quality life by Minnesota Living with Heart Failure Questionnaire, functional NYHA class, heart rate variability, and biomarkers like HSCRP and NT-proBNP. These were the various sites, and I was principal investigator from the clinical site of Sanjeevani. There was Medanta, KIMS, and multiple other hospitals that were part of the study. So the trial actually, the study actually looked at the beyond consenting, the left versus right side randomization, and then there was a titration. So every follow-up, the output and the cycles were modulated and regulated for 10 weeks, and this cyclic venous therapy was then followed up for 6 months, looking at the outcomes every 3 months. So what it is, basically it is the device which has got already multiple implants, more than 1 million implants now worldwide, in epilepsy and refractory depression, where it is implanted on the left or right vagus nerve by a carotid dissection by neurosurgeons, and of course the lead doesn't go to the RV lead, so the only thing that goes is a pectoral generator, and then it's implanted to the tunnel into the carotid artery, carotid sheath into over the carotid nerve, through that into the carotid sheath to the vagus nerve, and that's how the polarity is towards the brain in patients with refractory epilepsy. All that has been now done is the polarity is reversed, and now the current goes from the vagus nerve towards heart rather than going towards the brain. So chronic intermittent stimulation was devised with 10 hertz of 250 microsecond pulse width, with VNS intensity was titrated over weeks to maximum tolerable current below the threshold of side effects, that is alteration of voice or hiccups, which was the only side effect noted, and ECG was monitored to confirm no acute changes in the heart rate. Over time, the side effects they went off as the with the time went by, and average stimulation current was 2 to plus minus 0.6 milliampere. These are the baseline characteristics, left versus right. You can see not pretty much any major difference. Most of the patients were male. You can see that class 2 patients and class 3 patients, there were some more, almost equal amount, though slightly more in class 2. Baseline EF was around 32%, LV end systolic dimension of 51, and LV diastolic dimension of 62. So these were pretty much enlarged heart with a baseline heart rate of 78. These patients were already on beta blocker, and none of these patients previously had an ICD. The one that you saw was the later images that may be emerging. You can see that almost 100% were on beta blockers, 83% to 87% on AS or ARB. Remember, this is a pre-ARMI study. Aldosterone antagonists, digoxin, and loop diuretics were also there for the symptoms. And you can see that commonest side effect that was found was the cough or oropharyngeal pain. Otherwise, there was no local implant related infection, and unrelated events or pooled were more, but related events were not many. So primary FAC outcome, you can see that the left ventricular ejection fraction, though, did not change much in this, improved drastically by 5 to 10%. But what was most significant was the LV end systolic volume, which reduced. You can see these all values: LV end systolic volume, NYHA class, 6-minute walk test, Minnesota heart failure questionnaire, heart rate variability, heart rate drop by 3 to 4 beats, and NT-proBNP was not significant, but CRP values were significantly reduced. So to conclude, Anthem HF approach to ART on either side, left or right, was feasible, well tolerated, not any safety concern, with improvement in the cardiac function and heart failure symptoms, and further investigation in a controlled study was recommended. And then it came, Anthem HF was followed up with by Anthem, followed by Anthem long-term follow-up, and then came ENCORE, and then ENCORE extension, and we all have published these multiple papers. But what has happened is now this is another device, not the same device, which has got FDA approval for its trial that has been done in the US and the other part of the world. So this is Barostim device, which is actually approved for the same therapy in patients who have refractory heart failure, who have narrow complex, who are not eligible, or CRT, or who are symptomatic despite ICD or CRT. Those patients were only eligible. And narrow complex patients, this is the new proposed new algorithm. Of course, it's not something that's been implemented yet, but you can see that anybody who's got narrow QRS and ICD is already done, and patients still remain symptomatic in class 3, these are the patients you can consider for BAT, that is autoregulation, baroreceptor autoregulation treatment. So it can be with or without ICDs if the patient is not eligible for CRTs, that is. And of course, in class 4 patients, you would still stick to the CRT and ICDs, but class 3 patient is placed where this therapy can still find a role, and with waiting for the new outcomes, maybe we'll have it for class 2 as well later on. Thank you.
Yeah. So thank you very much. This is a privilege for me to be speaking in this forum, and I'm speaking upon some interesting TAVR case, which a few months back I have done, and I thought it is worthwhile sharing this because there is a lot of education in this case. And you know, our TAVR journey is becoming consolidated day by day, and our numbers are growing. So I think more the challenges which we confront during a TAVR case and we discuss amongst all of us in these forums, it's going to make us more wiser how to handle these situations for our future patients. So interesting TAVR case, and practically the interesting point in this was the coronary access and fear and scare of a coronary occlusion. So coronary artery disease and aortic stenosis, they are known to be coexisting with each other. And as per literature, the need of PCI post-TAVR, although is not very high, but it's not uncommon also. The future may look different as we now offer TAVR in low-risk cases. So what this practically this slide means is that if we do a TAVR, and even at that point of time, patient doesn't have a coronary artery disease, we have to think that if the patient develops a future coronary artery disease, how to handle that. So this is my case. He was 56-year-old, not very old patient, but this is also one point which I like to enumerate. Normally, we consider TAVRs in above 65 years of age patients, but in some of the other patients where the morbidities are very high and surgical risk is very high, it can be thought of. This procedure can be thought in such patients also. So this was the same patient. He had many comorbidities. He had renal cell carcinoma. He had frequent urological infections. And given that, the family was very clear that they are not going for 2 surgeries because he was posted for renal cell carcinoma surgery also. And in the workup, he was found to be having a critical aortic stenosis. So we sat as a heart team, which we usually do in all cases of TAVR. So heart team decision was very clear to go ahead with TAVR. And given the age, we opted for a valve, which potentially gives the largest effective orifice area. So that was our selection, and in that I would say without any inhibition, I think Medtronic evolute valve is one valve which gives us a better orifice areas in terms, because it's a supraannular valve, so openings are much better as compared to all other valves available. In this patient, the critical junctures, critical points were a narrow sinus of Valsalva diameters, borderline left coronary artery ostia. So this is also a point which needs to be discussed in such patients. How do we plan? So this is the CT analysis. Now, if you see very clearly, so it was the sinus of Valsalva on the left side was hardly 25. So it was not a spacious anatomy. And the left coronary artery ostia, left main ostium from the annulus was 9.2. So less than 10 is a clear red flag, and we need to be extra vigilant and extra cautious if we are planning a procedure with some red flags. So these are the two red flags, that sinus of Valsalva was narrow and the coronary ostial height, the left main coronary ostial height was less than 10, again a red flag. All other parameters were okay, but this is a big thing. So these are the femorals, common iliacs, very spacious, no problem here. And then we went in for the procedure. As a step number one, we do the coronary angio, obviously more than 50 years of age. The coronary anatomy, coronary arteries were fine. There were no critical blockages in the coronaries, but as I mentioned, the main point of interest and point of concern is the red flag sign of left main coronary ostial height is narrow. And then this is how the puncture is taken. I think not a great deal. We check from the contralateral side, do a femoral angiogram, and based on that, we see the profunda rising, and then mark up our point on the femoral head, femur head, to make a mark where to puncture. And then we go with the micro puncture, and then step up with a normal wire and a sheath. So after having done that, this is the aortogram with a pigtail catheter. See, now this also defines, if you see it very carefully, see, it's a constrained anatomy. And if you see, there's a thick valve, and valve is moving towards the left main ostium and almost reaching the height of left main ostium, covering the left main ostium. So this was the point where we were absolutely concerned that we should not be putting, making the patient vulnerable or vulnerable for coronary occlusion once we do the procedure. So I was very clear from the word go that we need to protect these coronaries. Sinus of Valsalva constrained and a left main ostial less than 10. We need to protect. I think this is clearly written on the wall. And following that, side by side as we progressed, we crossed the aortic valve, and this is a rigid wire into the LV, confida wire. And then after this, I engaged the left main, and see a wire is into the left circumflex. And over that wire, I passed a guide liner. So once a guide liner is into the circumflex over the wire, I retracted the guiding into the ascending aorta. So this is one important thing. Few operators also do differently by placing a stent, by harboring a stent into the circumflex or into the LAD, and then do not take guide liner. But this is a better approach, since we are not opening any stent. We are just harboring the guide liner into the coronaries, and then proceed on with our TAVR deployment. So after having done that, so this is a Medtronic valve, and see, slowly and gradually we were opening this valve. We got a good height as regards the annulus. So we were 3 down the annulus, and we were almost 80-90% open the valve, we are still at a point of retrieval. We can retrieve the valve still. And at this point, we waited quite patiently because there have been reports that coronary occlusions can happen even few hours after the valve deployment in TAVR. So it's not necessary that all the occlusions would happen on table. It can happen 1 hour or 2 hours after the valve deployment. So we have to be really vigilant and be safe totally, because once it happens, nobody will get a time to save a patient. So it means a life, we are practically dealing with a full life. So see, now we are constantly checking with the aortogram repeatedly whether coronaries are flowing. Our guide liner is still in position into the left main, into the circumflex, and almost waited there for 20 minutes and checked by both means, by a aortogram and by a selective injection through that guide liner into the coronaries. So we have deployed the valve here after having established that the flow was not impeding or not a slow flow into the coronaries by both injections, by aortogram and selective injections. But despite that, we kept our guide liner even after deployment of the valve. And again, we waited for 15 to 20 minutes. I think it's worthwhile making a sure assessment of the situation, whether nothing is happening or any vulnerability for coronary occlusion. We again waited for 15-20 minutes, kept on checking with this guide liner coronary perfusion. See, it's quite narrow actually. The margin where occlusion can happen or patient is safe is very narrow in certain patients. And this was a similar patient like this. Now, if you can see, as far as height is concerned, the native valve, which gets twisted behind this metal rim, actually is almost reaching the left main ostium, but there is some extra space of that sinus valsalva which is continuing the perfusion. So, but we waited. So the reason why we waited, because even if a obstruction or a slow flow or a TV1 flow starts happening into the coronaries, we can still take a stent and make a chimney to save a patient. But if we take out this guide liner and then the obstruction starts, then the occlusion starts, then we are left with nothing. So we waited 20 minutes prior in that position where the valve was not fully deployed, and 20 minutes after, almost 40-45 minutes, even after the valve deployed, once the flow was absolutely fine, brisk, and we could actually see that that small extra space of sinus valsalva is leading to a good perfusion. Then we take out our guide liner back, and that was the end of the procedure. As far as valve was concerned, there were no gradients. The mean gradient was only 5 millimeter of mercury post valve deployment, and there was no AR. So we were pretty happy with the valve position, outcome, and the red flag of low coronary ostial height. We took these steps to make sure that we are safe and patient is safe. So TAVR is a very powerful therapy, very patient-friendly therapy. Choosing the right candidate becomes very critical. We should clearly know the red flag signs, where to do TAVR and where not to do TAVR, or where to actually practice a special actions or special points to save and have the best outcomes with a patient who is undergoing TAVR. Keep all necessary hardware available. So this is again very important. The guide liners, the stents, the larger stent which could fit in from a left main to chimney if required. You should have all those things in your hybrid lab. Choose a device based on a risk allowing maximum safety. In this case, a recapturable, repositionable, a biggest effective orifice area valve was chosen because patient was relatively younger and there was some risk of occlusion. So we could actually manage by keeping the valve, and once it is still not fully deployed, we can still do a lot of maneuvers to keep the patient safe. In case it is a single shot balloon mounted valve, it is done, and if occlusion happens, we can't do anything then. So this is my case. Hopefully it is going to be quite educative for the audience. Thank you very much for giving me, for inviting me here. I really enjoyed. Thank you.
Good evening. Today I'm talking about winking coronary sign, which was published by us. Good evening. Today I'm talking about winking coronary sign, which was published by us in a PubMed Index journal. And I'm going to try to explain what is a winking coronary sign. So winking coronary sign basically is a sign of angiography of ventricular septal rupture. Ventricular septal rupture is an uncommon but lethal complication of acute MI, and its prompt recognition is important to permit timely institution of corrective measures. Basically, it's a novel, unique angiographic sign, and it's an angiographically diagnosing a post-MI ventricular septal rupture, and also called as Kamal-Sharma sign. It's defined as a partial transient occlusion of infarct-related culprit artery over the site of ventricular septal rupture during ventricular systole with near normal filling in the diastole. So basically, this is how it looks like. You can see the LAD, this patient, and you can see the mid LAD actually winking, actually closing down transiently, and the dye flow is stopping in between. So this is a patient whose angiogram was done post-stenting. Actually, you can see somebody has already put a stent, and then this patient underwent an angiogram, which goes on to show the winking of the mid LAD. So this was first reported by us in Journal of Cardiovascular Medicine and Surgery, where we presented analysis of 15 patients, and we found out that the 15 patients who had this sign, almost all, 13% of them had anterior wall, and 2 patients had inferior wall MI. The circumflex as a culprit was never found because probably of the annular fibrous tissue that the circumflex runs over the AV groove. Only 1 patient had completely occluded infarct-related artery, and then it became apparent once the artery was opened up, and this was the first publication of the same. Then we, of course, went ahead and did a retrospective observer-blinded case-controlled study of 129 patients. Of it, 56 were consecutive VSR secondary to acute MI, who had undergone cardiac cath between August 2008 to 2017, over a decade. And these cases were compared with 73 age and sex matched controls with STMI without a VSR. So all the angiograms were reviewed, analyzed by 3 different interventional cardiologists who were trained to recognize VCS, but were not aware whether the ventricular septal rupture was present or not. So winking coronary sign was considered to be present if it was confirmed independently by all the 3 of them. And these were the results. You can see that it was, of course, more common in patients who were diabetic and hypertensive, and patients had good TB grade flow. Unless the artery is not flowing, then we will not be able to see. But as you can see, in the VSR group, almost 57% of the patient were having TB grade 3 flow. Thrombolysis was performed in almost 1/3 of the patient, and the winking coronary was present in the VSR group in 38 patients, which is around 67 or 67% or 2/3 of the patients. So this is basically systolic compression of the culprit vessel. Here you can see the LAD and near normal flow in diastole in the patient with anterior wall VSR. This is our data. You can see its sensitivity is almost 67.9%, but it was 100% specific with 100% positive predictive value. It was observed, whereas none of the patients without VSR actually showed the winking coronary sign. So The absence of winking coronary sign among patients without VSR resulted in a good positive predictive value, though negative predictive value could not be calculated because of very low prevalence of the sign in patients who did not have a VSR. So there are various postulated mechanisms that we have proposed. One is the Venturi or the mechanical theory, three theories, the Venturi effect, the mechanical theory, and the hemodynamic theory. The Venturi effect basically is that when the shunt across the VSR leads to a rapid drop in the pressure across the defect, causing overlying artery to collapse, and hence there is a systolic wink of the artery overlying the rupture. Second theory is the mechanical theory. It's the anatomical disruption of the septum because of the mechanical movement per se, that the artery itself can get compressed, and hence the rupture site causes transient loss of flow in the coronary artery. Mechanical instability of the disrupted septum may also be responsible, not the movement, but the hemodynamic impairments can actually be responsible for it. So we all know this is the blood supply of interventricular septum, and that's why it runs just on the anterior part of the groove, while the PD runs on the posterior part of the groove. And you can see this is a patient with the right coronary artery. It's a post-10. You can see that this patient has got a wink in the PD. And this is again corroborated with a device actually that was implanted in this patient who had a winking of the posterior descending artery or the right coronary infarction. So again, this goes on to show the wink. You can see here the mid part of the PD, which is winking with an acute infarct related ventricular septal rupture. And this was corroborated on a surgical device. You can see correlation as well. The device was implanted and it corroborated with the site of the wink. This is the VSR device, which was put along with an intra-aortic balloon pump. And this is how the VSR can often correlate. And this is, of course, the other one. So this is the second publication in series, as I mentioned, in the Indian Heart Journal about the accuracy of the winking coronary angiographic sign. So one can learn a lot just by good observation. Thank you. Thank you very much.
Hello everyone, I am Dr. Pooja Vyas. Hello everyone, I am Dr. Pooja Vyas. First of all, I would like to thank Dr. Kamal Sharma sir and his team for giving me this opportunity. Topic given to me is echocardiographic quantification of aortic stenosis. So scenario given is 80-year-old female and being treated with nitrates for angina, and whose previous angiogram 10 years back was suggestive of 30% lesion in LAD, and now she presented with dyspnea class 2 and angina class 3, and on auscultation there was an ejection systolic murmur with soft S1 and S2, and the junior resident is confused as his outside echo report is showing moderate aortic stenosis with fair LV function. So how would I quantify the severity of aortic stenosis using echocardiography? So first of all, let us go through the stages of valvular aortic stenosis. Stage A includes patients who are at risk of aortic stenosis with aortic Vmax of less than 2 meters per second. Stage B includes the patients with progressive aortic stenosis, which includes mild aortic stenosis and moderate aortic stenosis. For mild aortic stenosis, Vmax should be between 2 to 2.9 meters per second, and the mean pressure gradient should be less than 20 millimeters of mercury. And for moderate aortic stenosis, aortic Vmax should be between 3 to 3.9 meters per second, or mean pressure gradient should be between 20 to 39 millimeters of mercury. Now, stage C includes asymptomatic severe aortic stenosis patient. Severe aortic stenosis is considered when we get aortic Vmax of more than or equal to 4 meters per second, or mean pressure gradient of more than or equal to 40 millimeters of mercury. And at that time, aortic valve area typically is less than or equal to 1 centimeter square. And very severe aortic stenosis is when aortic Vmax we get is more than 5 meters per second, or mean pressure gradient is more than 60 millimeters of mercury. Now, stage C2 are the patients who are asymptomatic severe aortic stenosis patients with LV dysfunction, while stage D includes the symptomatic patients with severe aortic stenosis. So the severe aortic stenosis here can be of three types. D1 includes those patients with high gradient, high flow aortic stenosis. And D2 includes those symptomatic patients with severe low flow, low gradient aortic stenosis with reduced ejection fraction, and D3 are the patients with paradoxical low flow severe aortic stenosis, which we will discuss later on. The goals of echocardiographic evaluation for aortic stenosis are to establish the diagnosis of aortic stenosis, to quantify the severity of aortic stenosis, and assess the left ventricular function. So Doppler assessment of the aortic stenosis usually starts with measuring the peak transvalvular velocity and then mean transvalvular gradient, and then comes the continuity equation to determine the aortic valve area. So echo window to be used to measure these velocities and gradients are apical 5-chamber view, suprasternal view, and the right parasternal view. Multiple views are to be used, and we should take care that Doppler beam should be aligned with the direction of the stenotic jet to get the perfect aortic velocities. Simplified Bernoulli equation is used to estimate the peak gradient, and this equation is a proven practical and non-invasive method for determining the pressure gradient across the aortic valve, and it correlates very well with the invasive pressures and gradients. So from the Doppler recording, by using the equation P equal to 4V square, here the velocity is taken in meter per second, and we can get the maximum pressure gradient across the stenotic valve. And to get the mean pressure gradient, another equation is there. So the mean pressure gradient equal to the maximum pressure gradient upon 1.45 plus 2 millimeter of mercury. Usually this is calculated by the software. It utilizes the data of the instantaneous velocities across the aortic valve, and it provides the value. So usually it is software generated. So here the color wave Doppler is put across the aortic valve in the 5-chamber apical view, and what we get is the aortic velocity jet. And by tracing this aortic jet, we get that maximum velocity is 2.6 meter per second. So it suggests that it is mild aortic stenosis. And aortic stenosis should be quantified not only in one view, it should be quantified from the multiple views. See here in the figure 1, the aortic velocities were taken from the apical 5-chamber view, and it showed the velocity of 3.9 meter per second, while the right parasternal view showed the velocity of 4.8 meter per second. So if the peak gradient would have been underestimated if the echocardiographer had concluded the examination with the apical views rather than moving to the right parasternal window where the higher velocity was recorded. Limitations of pressure gradient calculations. We should know that these valve gradients are dynamic, so it varies with heart rate, loading condition of the heart, blood pressure, and the inotropic state of the heart. So if there is malalignment of the jet and the ultrasound beam, it will lead to the underestimation of the pressure gradients. So any underestimation of the aortic velocity, it will result in the greater underestimation of the gradient, because the pressure gradient is equal to 4 by V square. And there is also one limitation, that due to the similarity in the location of the mitral regurgitant jet and the similarity of the location of the aortic stenosis jet and the direction of the jet, we may get confused with the MR jet. And in aortic regurgitation, usually the stroke volume is higher, so the flow across the valve during the systole will be higher, and it will lead to the overestimation of the aortic stenosis if there is coexistent aortic regurgitation. And in LV dysfunction, opposite will occur. Due to reduction in the stroke volume, there will be false underestimation of the pressure gradient. So it will lead to the underestimation of the aortic stenosis. Here see, due to the similarity in the location and the direction of the flow of the aortic stenosis and mitral regurgitation, there may be a confusion between AS and MR. So how to resolve that? See here, the vertical line, it provides a representative line in relation to the QRS complex. So there will be the gap between a vertical line and onset of the flow in aortic stenosis, while the mitral regurgitation, it starts with the isovolumetric contraction phase and it continues through the isovolumetric relaxation phase. So the duration will be more in case of mitral regurgitation. So complete evaluation of the quantification of the aortic stenosis includes aortic valve determination of aortic valve area using the continuity equation. And this continuity equation is based on the principle of conservation of mass. And the continuity equation states that the stroke volume proximal to the aortic valve must equal the stroke volume through the stenotic orifice. And because the stroke volume is the product of the cross-sectional area and the time velocity integral, the continuity equation can be arranged this way that aortic valve area equal to cross-sectional area of the LVOT into a time velocity integral of the LVOT upon time velocity integral of the aortic stenosis. So to calculate the aortic valve area, we need three measurements. One is the cross-sectional area of the LVOT. Second is the time velocity integral of LVOT, and TVI of the aortic stenosis. To calculate the cross-sectional area, we need the cross-sectional area is calculated by this formula pi r square, and the diameter of the LVOT should be taken in the plex view, while the time velocity integral is to be taken in 5-chamber apical view just proximal to the aortic valve by putting the pulse wave Doppler imaging. So it gives the time velocity integral of the LVOT. And by putting the continuous wave Doppler, we can get the aortic stenotic jet. And by this, by tracing this aortic stenosis jet, we can get the TBI of the aortic stenosis. So this is an example where the diameter of the LVOT is 2 centimeters. So radius is 1 centimeter. And by that, the cross-sectional area is 3.14 centimeters square. TBI of the LVOT is 11 centimeter. TBI of the aortic stenosis is 59 centimeter. And by putting these values in this formula, we'll get the aortic valve area of 0.6 centimeters square. And there is even a simplified version of this continuity equation where this TVI has been replaced with the maximum velocity across the LVOT and maximum velocity across the aortic valve. Considering that the flow duration across these two places is the same. So we can even calculate aortic valve area using this formula. And the continuity equation has two important advantages as compared to Bernoulli's equation. One is if there is coexistent aortic regurgitation, Bernoulli's equation will overestimate the aortic stenosis, while continuity equation will not have that effect on it. And similarly, with LV dysfunction, there will be reduction in the stroke volume. And so the Bernoulli's equation will show the underestimation of the aortic stenosis, while that will not occur with the this continuity equation. So there are some limitations of continuity equations too. So there is intra and inter-observer variability. So variability is noted around 3 to 4% while measuring aortic stenotic jet and LVOT velocity, and somewhat higher for measuring the LVOT diameter. It is around 5 to 8%. And when we have subaortic flow velocities abnormal, then stroke volume calculation at this site is not accurate. And other potential factors that can contribute to errors are image quality, annular calcification, non-circular annulus, and failure to measure the true diameter. So it is very important to measure the accurate LVOT diameter. It is because when we calculate the aortic wall area, the cross-sectional area is pi r square. So if there is even a small error, so it will be reflected highly in the final equation, because it is in the equation the radius is squared. So the smaller error can lead to the big error finally. So we must take care while calculating the LVOT diameter. So according to SEC AHA guidelines, we can say we will differentiate the aortic stenosis into mild, moderate, severe, and very severe category. So mild aortic stenosis is when aortic wall area is between 1.5 to 2 centimeters square and mean gradient is less than 20 millimeter of mercury and jet velocity is 2 to 2.9 meter per second. Moderate aortic stenosis is when the wall area is 1 to 1.5 centimeters square. Mean gradient is between 20 to 39 millimeter of mercury and jet velocity is between 3 to 3.9. We will say that aortic stenosis is severe when aortic wall area is less than 1 centimeter square and mean gradient is more than or equal to 40 millimeter of mercury and jet velocity is more than or equal to 4 meter per second. And very severe AS with wall area of less than 1 centimeter square, but the gradient here is even higher, more than 60 millimeter of mercury, and peak velocity is more than or equal to 5 meter per second. So severe AS can be of 3 types. It can be either high flow, high gradient, normal LV with normal LV ejection fraction. It can be of low flow, low gradient with low LV ejection fraction, and low flow, low gradient with preserved ejection fraction, which is paradoxically low flow severe aortic stenosis. So here comes the role of dobutamine stress echo. So whenever there is LV dysfunction with severe aortic stenosis, there can be 2 diagnostic possibilities. Either it can be true anatomically severe aortic stenosis or it can be pseudo-severe aortic stenosis. By saying pseudo-severe aortic stenosis, we mean to say that it is not severe, but it looks like severe aortic stenosis. So it is just mild to moderate aortic stenosis where the wall leaflets are not opening fully, and it looks like severe aortic stenosis because the stroke volume is low. So dobutamine increases the stroke volume. It allows the differentiation between these 2 possibilities just we discussed, and we assume that the test assumes that if the leaflets are relatively flexible, the wall area will increase in response to the increase in the stroke volume. And if there is true severe aortic stenosis, which has a fixed wall area, so the wall area will not change with the dobutamine infusion. So if there is pseudo severe aortic stenosis, wall area will increase. The dose used for dobutamine stress echo is we should start from 5 microgram per kg per minute in a 5 microgram incremental value every 5 minutes up to maximum of the 30 microgram per kg per minute, or until the LVOT velocity or VTI reaches the normal value, like until the LVOT velocities are between 0.8 to 1.2 meter per second, or VTI between 20 to 25 centimeter. So in case of true aortic stenosis with dobutamine stress echo, there will be increase in the peak velocity and VTI of both LVOT as well as aortic wall. So the ratio of VTI, LVOT VTI to aortic velocity VTI, it will remain constant. And the aortic wall area by continuity equation will be less than or equal to 1 centimeter square. But in case of pseudo-severe aortic stenosis, Due to the dopamine, there will be higher stroke volume. It will lead to the increase in the excursion of the aortic leaflets, and it will lead to the increase in the aortic valve area. So with the dobutamine infusion, there will be increase in the aortic valve area. There will be increase in the LVOT VTI, which is far greater than that of the aortic valve VTI. So the ratio of LVOT VTI to aortic valve VTI will increase. So if there is increase in the aortic valve area with infusion of the dobutamine to more than 1.2 centimeter square, it is confirmatory that this patient has pseudo-severe aortic stenosis. So this image shows that first image shows this is dobutamine stress echo and severe aortic stenosis with normal function, which has high gradients, severe aortic stenosis with low gradients, and with the infusion of dobutamine. So there will be this, the ratio will remain constant. LVOT to aortic valve VTI ratio is constant, 0.2. While in case of the pseudo-severe aortic stenosis, the ratio increased. And see here, the ratio is now, it has increased from 0.2 to 0.3. So as we are discussing dobutamine stress echo, we must discuss contractile reserve also. So by definition, contractile reserve is increase in the stroke volume of more than 20% with dobutamine. And it is measured as 20% increase in the LVOT VTI by pulse wave Doppler. So failure of ventricle to augment with dobutamine, it predicts a poor outcome with aortic valve velocity, and the perioperative mortality will be as high as 50% if there is no contractile reserve. So response to dobutamine stress echo can be with true severe AS, AV gradient will increase, stroke volume will increase, and aortic valve area will not change with true severe AS. But if there is pseudo-severe aortic stenosis, means there is it is functional aortic stenosis with mild to moderate aortic stenosis, aortic valve gradient will increase, stroke volume will increase, but with that aortic valve area will also increase, and usually it increases to more than 1.2 centimeter square. And where there is no contractile reserve, there will be no change in AV gradient, stroke volume, or aortic valve area with dobutamine infusion. Now paradoxical low flow severe AS. So to define paradoxical low flow severe AS, patient must have LV ejection fraction of more than 50%, and aortic valve area by continuity equation should be less than or equal to 1 centimeter square. Aortic Vmax by Bernoulli's equation should be less than or equal to 4 meter per second, and this pressure gradient should be less than 40 millimeter of mercury, and the stroke volume index should be less than 35 ml per meter square, and measure when the patient is normotensive with blood pressure, systolic blood pressure of less than 140 millimeter of mercury. Here, what happens with severe AS, there will be concentric LVH, and it will lead to smaller ventricular cavity, and this LVH will lead to the reduced LV compliance. So ultimately, this all things together will lead to reduced stroke volume, and so low stroke volume will give us paradoxical low flow severe aortic stenosis. So this is all we discussed about the echocardiographic quantification of aortic stenosis. Thank you very much all.
with acute inferior MI, with RVMI, with window period of 5 hours, with blood pressure of 80 by 55 millimeter of mercury, with past history of hypertension and diabetes, preloaded with clopidogrel and aspirin with heart rate of 34 beats per minute, has a complete heart block with symptoms of giddiness. His radials are feeble. The preferred route of PCI would be, of course, radial. Even if the temporary pacemaker is needed, even then the radial route is the preferred modality. Let me tell you, the internal jugular vein access is a default route for TPI at our center. TPI can be easily done using IJV. It is more convenient to the patient as there is a freedom of movement. Lead position is more stable compared to femoral vein. It is a good site for maintaining sterility compared to femoral vein. Let us see what literature says. So this is transjugular insertion of a temporary pacemaker a safe and effective approach? This was published in PLOS 1 to 2020. The aim was to compare the procedure time and complication rates between the transjugular and transfemoral approaches for TPI, analyze 732 consecutive patients who underwent TPI, from which 361 were in transjugular approach and 371 were in transfemoral approach. The conclusion was the procedure time was significantly shorter in the transjugular approach group. The risk of reposition was significantly more in transfemoral approach group when the temporary pacing was continued for more than 3 days. This is another trial. It's a 5-year study with temporary pacemaker therapy in coronary care unit, published by Mayo Clinic Proceedings, where 1,022 consecutive patients who received temporary transvenous pacemaker in coronary care unit during the 5-year period were studied. And the conclusion was the right internal jugular approach was associated with the lowest complication rate. This was another study, a review of temporary cardiac pacing wires published in Indian Pacing and Electrophysiology Journal. The aim was to determine the best route of venous access for TPI and find the ways to reduce the complications. 3,700 patients from 15 studies were included. And the results were the internal jugular veins was associated with lowest complication rate and ease of access. The antecubital fossa veins have the highest complication rate. Internal jugular veins are the preferred route for the access, followed by subclavian and femoral veins. The right side should be used whenever it is possible. Guidelines from British Cardiac Society recommend the right internal jugular vein as a route of choice for temporary pacing. Now we all know the advantages of radial route for angioplasty, less incidence of access site major bleeding and blood transfusions. Major vascular complications are rare. If anatomy is not suitable for PCI, thrombolysis option can be easily offered to the patient as the bleeding risk from cadal site is negligible. This is very important because patient is diabetic since many years. Glycoprotein 2B3A inhibitors can be used without any hesitation. There is no restriction in limb movement after procedure, early ambulation, and the patient with severe LV dysfunctions are not confined to supine position. For experienced radialists, puncture in feeble radial is not a problem. Number of studies have shown morbidity and mortality benefit of radial route in acute MI with cardiogenic shock. Let us see the publications. These are the pooled data of nearly 7,000 patients from 9 studies where major vascular complications were studied, which shows TRI group major complication rate, major vascular complication rate was 0% compared to TFI, it was 3.8%. Radial versus femoral access for rescue PCI with RioPro use. This was published in Canadian Heart Journal. The conclusion was the no access site related major bleeding in radial group versus 9% complication in femoral group. The impact of bleeding, hematoma, and transfusion on the procedure outcome. So this study was published in CCI 2007. The excess site hematoma requiring blood transfusion predicts mortality in the patients undergoing percutaneous coronary intervention. This was the data from National Heart, Lung, and Blood Institute of Dynamic Registry. And the conclusion was excess site complications, especially hematoma requiring transfusion, remains a very important predictor of adverse procedural success and patient outcome. The in-hospital mortality was 9.9% in hematoma group versus 1.2% in non-hematoma group. Impact of major bleeding on 30-day mortality and clinical outcomes in the patient with acute coronary syndrome, published in JACC 2007. The results were patients with major bleeding had higher 30-day rates of mortality, 7.3% versus 1.2% in radial group, and more incidence of stent thrombosis, that was 3.4% in femoral group versus 0.6% in radial group. Conclusion, the major bleeding is a powerful independent predictor of 30-day mortality in patients with ACS managed invasively. Transradial versus transfemoral approach for the percutaneous coronary intervention in cardiogenic shock. This was published in Archives of Cardiovascular Medicine 2015. 101 consecutive patients admitted for PCI for acute MI with cardiogenic shock were treated. 74 patients were in transradial group and 27 patients were in transfemoral. The rates of PCI success were similar in both groups. At the mean follow-up of 756 days, the death occurred in 54.1% patients in transradial group versus 81.5% patients in the transfemoral group. And the conclusion was the transradial approach in the setting of PCI for ischemic cardiogenic shock is associated with dramatic reduction in mortality and should be preferred to the transfemoral approach in the radial expert centers. ACC, AHA, and Society of Cardiovascular Angiography and Intervention guidelines place TRA for PCI in acute coronary syndrome as a class 2A indication with the level of evidence A, and European Society of Cardiology guidelines now place TRA for PCI in acute coronary syndrome as a class 1 indication with the level of evidence A. So clearly choice is IJV route for TPI and radial route for PAMI. Thanks.
First of all, thank you very much to Kamal for giving me this again an opportunity. And Kamal is just like a younger brother, and we are working together since 20 years. So it is always very good to feel when to come in this conference and present, because it's a very good academic feast, and Kamal is a thorough academician apart from his practice also. As far as Sanjay Bhai is concerned, he is the master of the he's the master radialist. We have learned a lot of things from him. He was just immediate senior to me. So as such, there is no debate as such. Sanjay is always a winner. But still, because this topic has been given to me, so I will just speak some few things for that. So femoral versus radial approach for emergency intubation, the case of femoral approach in radial first era. We all know that the radial first era, even I may go for radial first. So just coming, तुम्हारे उसूल तुम्हारे आदर्श किस काम के तुम्हारे उसूल. So this I will discuss it later also again. So as the scenario has already been discussed, 77-year-old female. Coming to the as already case scenario has already been discussed. The important point is radials are feeble, although it is in the hands of Sanjay. It is because he is so expert. It is with the blood pressure of 80, he can take easily radials. For it is not easy for everyone to take the radial with this blood pressure in cardiogenic shock, especially in a 77-year-old female patient especially with those so many young cardiologists now they are there. So as far as this even as already been discussed, ESC and all recommends the radial as the first route. However, same has not been studied widely in the second setting of cardiogenic shock and high risk PCI. Already, as Sanjay Bhai has discussed one study in which there are 100 patients with cardiogenic shock. But if you go through the literature, various trials that radial, rival, and all these semi-radial, all they excluded patient with the cardiogenic shock in the study. Exclusion criteria were this one. So coming to the PCI seminar, the management of patient with high risk acute coronary syndrome. In a STEMI patient, we all know that the time is muscle. With your experience, you should estimate yourself own that whether you will be able to do with the radial, especially those who are less experienced. So in a STEMI patient treated with an aggressive antiplatelet and antithrombotic, we all know that radial reduces the bleeding complications were performed just by experienced operator. The use of the femoral approach is preferred in hemodynamically unstable patient, and when you need a very rapid fast recirculation, especially if the you need large catheters and need lot of support. The radial axis with 6 French sheath will not give that much of support. So coming to a very important trial which is published, which has been in the JCC 2019, the Safari STEMI trial, which was conducted at 5 centers in Canada, for seeing whether the aim was whether determine if the radial axis improves survival when compared to the femoral axis in patient referred for primary PCI, because various previous trials say that radial axis is associated with lower mortality in STEMI patient. So just to confirm that. So the primary outcome of this trial was the all-cause mortality measured at 30 days. And the key secondary outcomes for the 30 days, the stroke, reinfarction, stent thrombosis, bleeding. So if you see the primary outcome, the 30-day mortality was approximately almost similar in both the groups, femoral or radial axis in this trial. This trial included all kinds of patients and the experienced operators, both for the radial and the femoral route. And the bleeding was definitely slightly higher, but not statistically significant in the radial group, in the femoral group as compared to the radial group. The conclusion of the trial was in patient with STEMI referred for primary PCI, we did not find a difference in survival at 30 days between the use of radial axis and femoral axis. Our findings suggest that adequately trained operators should be able to achieve similar results using either radial or femoral axis for primary PCI. So we all know the complications of various radial and the femoral routes, the common complications. But if you see the radial arterial anatomical variants, which are which might be cumbersome, especially in the emergency situation, in a 77-year-old female like complex radial arterial loop, then anatomical difficulties, and then the tortuous and radial artery with spasm, and the prone to spasm, small caliber radial artery, and then this like lusoria. So this is this can be difficult to, if you see the literature, the anatomical difficulties in the radial approach, that radial anomalies you can find in up to 10% patients, and procedure failure rate is about 15%, those with the anomalies. So advantages of the femoral approach in the emergency situation in the setting of cardiogenic shock: easier to access, being large caliber and no problem of spasm. So it is, even if it is a newcomer, it is relatively easy. Easy delivery of large sheets, and especially if you required IVP in the emergency situation, and even as I said, the temporary pacing. As Sanjay Bhai said that the transjugular route is good for the venous temporary pacing, I agree with that. But many of us are not experienced of doing temporary pacing with the transjugular route, because we have been trained in that way that we always did pacing from the femoral route. So especially when you are fumble in the emergency situation, and if you complicate the puncture in the transjugular route, then there can be problems. If you data review on radial versus femoral in the emergency setting, radial versus femoral for rescue PCI, no difference in major bleeding fluoroscopy time, and contrast use was similar, and the times of first balloon inflation was slightly longer with the radial axis. Chinese study on emergency PCI found no difference in outcomes, however, less vascular complications in the radial group. We all know that. UK study on feasibility of radial axis. Then, so why femoral? Studies point to the fact that when radial axis is achieved, it is better in terms of vascular complications, but only non-inferior to femoral axis. But the important thing is you should get the radial. That may not be possible with everyone to puncture the radial. Once you puncture the radial, then definitely the vascular complications are less, especially in patient with cardiogenic shock and feeble pulse in a 77-year-old operator. So axis is, as I already said, operator and experience dependent. And if you do it with adequate care, if you do a femoral axis and if you do it carefully, then the produces the same stud result and there is no increased reading as compared to the femoral root. So, and if you see the intra-arterial BP and femoral axis, femoral arterial BP are more closely correspond to central BP. Radial arterial BP underestimates true blood pressure by 15 to 20 mm of Hg. And you see various studies, the crossover from radial to femoral axis during challenging percutaneous intervention can make the difference between success and failure. And it has been found that the crossover from radial to femoral in various studies is between 6 to 10%. And especially it is more common in the female sex and with the anterior wall MI are the predictors of the crossover. So with the crossover, it takes more time so that your door to balloon time increases. So that as we said, the time is in muscle. So that time can get increased. The radiation exposure and vascular axis in acute coronary syndrome, the sub-study from the matrix, that is the red matrix trial, they can just go to the conclusion. Compared to the femoral axis, radial axis is associated with greater operator and patient exposure, radiation exposure, when performed even by the expert operators in current practice. This is not very old, this is 2017 article. So exposure and risk operator, radial operators has more radiation risk as compared to the femoral, but it is also again controversial. Many studies have not shown that the radiation exposure is similar in both. So for radial, if you see the fewer axis complication, it's preferable in patient with peripheral vascular disease, patient with morbid obesities, patient having extensive inguinal scarring, severe back pain or shortness of breath, and patient on therapeutic anticoagulation, and patient request, of course, and failed femoral approach. Why femoral? Complex cases, larger catheters and sheaths are required. If you require LV support, tower, small radial size, AV fistulas, anatomy, and patient requests. The limitations of the radial route is unpredictable course to ascending aorta, small radial artery caliber, challenging in cardiogenic shock, increased rate of crossover, radial artery spasm, main culprit to negotiate brachial loop, cardiogenic shock, independent predictor of transradial PCI failure, size of radial artery itself linked to sheath occlusion after removal. And radial approach usually requires more learning curve as compared to the femoral approach. No trial rival matrix compared ultrasound guided micropuncture transfemoral arterial puncture versus transradial puncture in reducing vascular complication. Routine use of radial axis create Compeu paradox. When we were the students, it was the femoral only. We have learned it from the femoral to the radial. But now, because of the started with the radial itself, the new residents and that those coming young cardiologists, they are straightway going to the radial route. So the loss of femoral experience, so more femoral vascular complications if you do not have the experience of the femoral puncture. So in conclusion, femoral axis is time tested, easy to apply, particularly in sensitive conditions like cardiogenic shock. Close proximity with femoral vein gives ease for temporary pacing if required, and deploying IBP and other devices can be achieved on femoral route due to large sheath requirement. And of course, with operator experience and due care, vascular complication may be made comparable to the radial approach. So as I already said, तुम्हारे असूल तुम्हारे आदर्श किस काम के हैं तुम्हारे असूल. This is the dialogue from very famous movie of Amitabh Bachchan. So when the radial root catheter arrives late at the coronary ostium, I am not talking of Sanjay Bhai, he's so experienced expert, but I am talking of general cardiologists. So my intention not to teach you a method, but just to give good reasoning. Thank you.
it has been introduced that we have an elderly male with non-ST elevation MI with blood pressure 170/90, preloaded with clopidogrel and aspirin, and has an ostial calcified 90% lesion with dominant circumflex vessel. And what should be the ideal pre-dilatation strategy? So as we know that angiography is insensitive as far as knowing the plaque distribution and composition is concerned. But if you have detected coronary calcium on fluoroscopy, on conventional angiography, at least on either side of the luminogram in at least 2 different views, you are likely to have complex coronary calcification, and there are higher chances that you might end up having plaques with a rim of calcium exceeding about 90 to 180 degrees. So we are likely to have significantly complex coronary calcification as far as this patient is concerned. We know that the presence of calcific stenosis is associated with markedly reduced final minimal stent area achieved after PCI, as well as the OCT showing the stent expansion index, which is also markedly different when you have significant calcium versus mild or no calcium. And it's not surprising that coronary calcium is supposed to be a strong predictor of strong stent failure. This slide is very much familiar to all of us. We know that for bed preparation for calcific lesions, there are 3 basic techniques. One is debulking, ablative, and balloon-based techniques. In this patient, let us say that if the patient is likely to have balloon crossability, the pre-dilatation strategy after having imaging done should be based on non-compliant cutting scoring balloon system. In this particular flow chart, there is no mention of a high pressure balloon-in-balloon system, that is OP and NC for all practical purposes, for the sake of discussion. So coming back to this patient with 78-year-old non-STEMI diabetes hypertension with the calcific lesion, what do we want for this patient? We want a procedural success that should be without MACE. We want a strategy success that PCI should succeed and patient should not have emergency CABG done. We want a technical success, that means crossability and deliverability of the hardware, especially balloons and stents. We need an angiographic success, meaning thereby no significant residual lesion. This definition may vary from various, the parameters may vary. Some would say that less than 10% should be the residual lesion. And in presence of calcification, at times the studies have said that even less than 30% lesion could be acceptable. Residual lesion could be acceptable. One of the important aspects as far as our geographic is concerned is the cost of intervention, which should be restricted, and there should be lesser need of additional complementary hardware used. And finally, the result, acute result, should be durable, and that would depend on the optimized result with imaging. So I think this is what I would want in given patient. Sharing just one similar case that we had recently, will not show the IVUS imaging, but we had a calcific LAD disease. You can see here fluoroscopically the stent boost image showing significant calcium. And if you see the IVUS image, again shows a significant arc of calcium exceeding more than 180 degrees. This patient, when we treated, we wanted to have a coronary blood preparation with plextome. After a routine NC balloon dilatation, plextome really could not cross the lesion. And in this patient, OP and NC, that is balloon-in-balloon system, could easily cross the lesion, and we could successfully prepare the bed. And this is what the final result of the PCI was. So this is just to show that how the coronary blood preparation successfully led to good stent expansion and optimal areas achieved. So the super high pressure balloon, that OP and NC by the SIS Medical, is a non-compliant balloon with a twin layer technology, and it is developed to deliver inflation pressures more than 35 bar and up to 55 bar. Now, is it surprising that the plextome or Scoreflex system could not cross, and the OP and NC balloon could cross? So if you see this chart very carefully, in this chart, we can very well see here the lesion entry profile of various cutting and scoring balloons, and the mid balloon profile of the same balloon systems. So lesion entry profile of practically every balloon system is more than 0.019 inch, and the mid balloon profile shortest is of Scoreflex, that is 0.032 inch. The newly introduced Wolverine has mid balloon profile of 0.036 inch and lesion entry profile of 0.017 inch. Now, if you compare this with the OP and NC system, the OP and NC has The lesion entry profile of 0.016 inch, which is least as compared to all previously documented the scoring and the cutting balloon systems, and the mid balloon profile is 0.028 inches. So balloon profile, despite ballooning balloon system that this OP and NC balloon is markedly lower as compared to the scoring as well as the cutting balloons. And it is not surprising, that's why that this can cross even in significantly complex lesions where the cutting or scoring balloons may not be able to cross. Now, coming to the issue of bed preparation. Now, we know that there is a proven role for optimization of stent result with OP and NC balloon, that is in the post-dilatation. But what is its role in bed preparation as far as pre-dilatation is concerned? Do we have data as far as this strategy with using OP and NC system is there? So recently in the Euro Intervention 2021, there is an article by Tobias Rude about super high pressure balloon versus scoring balloon, which is used to prepare the severely calcified coronary lesion, the ISAR calc randomized trial. I will go through briefly the data that has been published as far as the pre-dilatation strategy with OP and NC system is concerned. There were 74 patients randomized to 1:1 fashion at 5 centers in Germany and Switzerland. And these patients were randomized after unsuccessful lesion preparation with conventional NC balloons. And if we see the salient characteristic, the vessel diameter for these patients was about 3 millimeter, the lesion lengths were about 24 millimeter, diameter stenosis was about 70%. But if you see the end results of the study, what it shows is that the OP and NC balloon system was associated with markedly lower diameter stenosis post PCI, which was statistically significant when compared to the scoring balloon. And if you see the minimal lumen diameter post PCI, that was also significantly higher as far as post PCI evaluation is concerned, and that was much superior in patients with OP and NC balloon system compared to scoring balloon system. Whereas the final OCT evaluation did not really show significant difference as far as stent expansion index is concerned. But if you go into the smaller details, that there was additional requirement of additional hardware as far as optimizing the coronary bed preparation is concerned in patients with the scoring balloon system. So almost 32.4% of patients from the scoring balloon arm required additional non-compliant balloon dilatation compared to only 5.4% in the OP and NC arm. So this is one of the important parameters which was statistically significant as far as the observations are concerned. It is reassuring to know that whichever strategy you choose, if you see stent expansion on the optical coherence tomography, there is no significant difference. And OP and NC as well as the scoring balloon, both modality of coronary bed preparation resulted into almost equivalent stent expansion index on the OCT. So finally, all is well that ends well. And therefore, the study really did not show major difference in the outcomes of the patients. If you see the angiographic success, it was same. Strategy success was also the same in both arms. Procedural success, there was no significant difference. If you see the in-hospital MACE, it was not statistically significant. However, if you see actual numbers, numerically, we can see that in-hospital MACE was numerically higher in the scoring balloon arm as compared to the OP and NC arm, which has not shown a statistical difference. But I think still this small data, this small number also should be alarming, and we should be careful about this particular observation. So it is also reassuring to know that in both the arms, the extent of coronary perforations were not significantly high. Less than 3% of patients had it, and all of them could be treated with covered stent implantation. So this is the only randomized control data that we have as far as the coronary bed preparation is concerned in with the use of OP and NC versus scoring balloon. But I think based on the relatively short, small experience with coronary bed preparation with OP and NC, and large experience with the scoring and cutting balloon systems, and the data from which I have just shared, the ISAR calc data. If we relook at this slide, what do we want? Procedural success, strategy success, technical success, angiographic success, cost of intervention without increasing the need for additional complementary hardware and durability acute result with the use of OCT. I believe the high pressure ballooning balloon, that is OP-NC system, is most likely to yield optimal preparation. And I think with this, I'll end my talk here, and it would be interesting to have opinion and discussion with the panels. Thank you.
Operated the need for bed preparation in a LAD ostial lesion. So why would we hesitate to do a PCI for LAD ostial stenosis? And this again, surgeons would happily say that we would just put a mid-cab Lima to LAD, and that would do the case. So whenever we do, we have to be better than the surgeons in terms of safety and long-term outcome. All ostial lesions are essentially bifurcation lesions, 0-1-0 at the best, or it can even be 1-1-1 or 0-1-1. There is usually involvement of distal LMC and LCA ostium. And ostial lesions have high elastic recoil. They are different from mid-LAD or mid-circumflex lesions. There are concerns for side branch occlusion due to plex shift and dissection. So, as Dr. Chirag said, that ideally we should treat it as an distal LMCA bifurcation lesion, and imaging should be done in all cases. So probably if imaging is available, IVUS available, we would do IVUS in this case and assess the lesion severity, pre-procedural plan that appropriate stenting strategy, landing zones, whether circumflex or distal LMCA is involved or not, optimization post-procedure, and management of immediate complications, if any. Now, vessel bed preparation, what we aim at: minimize risk of dissection, maximize lumen gain, and the stent size and MLD to be achieved. Now, cutting balloon is a very old thing used in PCI right from about 2002 to 3. We were using cutting balloons. The advantages of cutting balloon: it reduces the vessel stretch and vessel injury by scoring longitudinal rather than an uncontrolled disruption of plaque. Entire force is focused on wire or blade edge mounted on balloon. It creates a fault line and a dissection which is in an orderly fashion. And we can go with lower balloon inflation pressure recommended with the cutting balloon. The risk of slippage when you are doing at ostium with a normal balloon, the risk of slippage and a dissection extending proximally would be disastrous either to the circ ostium or to the LAD, and plex shift is minimized with cutting balloon. Another thing, role of inflammation, that calcification and inflammation goes hand in hand. Which is the chicken, which is the egg, we don't know. And when we do balloon dilatation, there is inflammatory activation of vessel wall injury, which can lead to intimal hyperplasia and restenosis. Most of the inflammation studies are on intima and media, but when we do at high atmospheres, the perivascular and adventitial tissues come into play. And many porcine studies have showed that this might lead to long-term restenosis rate increase with high pressures. So cutting balloon can create equal MLDs or better MLDs with low atmosphere and low inflammation. This is how NC balloon expands. There can be dog boning effect, while with cutting balloon, when you go up to 8 to 10 atmosphere, you create a routine. This is Wolverine, which we are routinely using from Boston Scientific. This is the non-functional blade height is reduced, and then there is a cast pad of about 0.005 inch, right? And there is a T-shaped notch which has enhanced flexibility and fixation to pad. Now this is the mechanism of action. When the balloon atherotom, it creates microsurgical incision into the vessel wall and weakened areas which can be dilated at lower pressure, changing the lesion compliance. The most important thing here is dissection only in the needed place without balloon slippage, with changing lesion compliance, so that a low balloon atmosphere would lead to expansion. If plain POBA is done, there are chances of hematoma. Acute overstretch can lead to hematoma and recoil at 14 days. So cutting balloon in fibrotic lesions, osteal and bifurcation lesions, these are the advantages which we have already discussed. These are few trials. There are no trials between cutting balloon and high pressure balloons, but cutting balloons versus plain balloons which were available for osteal lesions, the primary success rate, procedural success, acute gain, late loss is much less in LAD ostium. These are two trials way back from 1999 and 2000. And then this is in cutting balloon. Whenever there is a bifurcation lesion, the immediate and 3-month follow-up of cutting balloon versus plain balloon, the procedural success of cutting balloon was much better than POBA, and post-procedure MLD was quite high. This is a reduced trial where, when used with IVUS, it reduced the MLD. It reduced the restenosis with cutting balloon. There are angiosculpt, this Lacrosse and Alpha. This was considered Scorflex. This was used in the trial, but it has nylon, and nylon definitely probably has inferior cutting effects. It scores more like a buddy wire than with cutting balloon. These are OCT images of cutting balloon device. With one inflation, it causes 4 clear cuts in the vessel wall, and with 2 inflation, much more, about 5-6 cuts into the vessel. Now, if in this case, how would we go? Probably we would do an IVUS. If LAD ostium shows an arc of more than 270 and shows superficial calcium all over, dense calcium all over, probably a rotational atherectomy would be the first choice with a low burr, so that it causes less inflammation, and then post dilatation after rotational atherectomy with a cutting balloon at a low atmosphere probably would be the ideal thing. There were 2 trials, 2016 and 2019, that effect of cutting balloon after rotational atherectomy in severely calcified coronary artery lesions, assessed with OCT, and the results were that calcium fractures were much better with cutting balloon. MLD was much better, 6 versus 5 with cutting balloon. Stent area was much higher with post cutting balloon than with conventional balloon. These are the OCT findings post rota, post cutting balloon. And if we see this is a proximal, so probably if we dilate either with rotablator or with a 2O balloon, there should not be much problem in crossing the lesion with a cutting balloon. Head-to-head trial with high pressure balloon, there are two trials, not in coronary, but in pulmonary artery stenosis and native hemodialysis fistula, where cutting balloon did much better than high pressure balloon in terms of success. Perforation rate was low and 6 months restenosis rate was quite low than the high pressure balloon. So for this patient, imaging followed by if necessary rotablator or a just plain balloon of 2O followed by cutting balloon would be best for lesion preparation. Thank you.
GLP-1 receptor agonist. This is the financial disclosure, and I'm going to talk from the perspective of GLP-1 receptor agonist as the the next choice for this patient. But as all of you and a lot of you would have seen the movie Three Idiots, these three guys who end up in a marriage and then they are told that आप कौन से side से हैं, आप bride के side से है कि bridegroom के side से हैं, तो they say हम science के side से हैं. So I think same here. I'm neither from GLP side nor DPP side or AGA side. I'm actually trying to be more neutral and from science side, I think. So that is what my focus will be. So we have this patient who has already been introduced. Like I said, 72-year-old, 90 kg weight. Its EGFR is 39, HbA1c is 8.9, its fasting is 212, postprandial 276, and LVEF is 48%. So this is the history with the past history of PTCA. Now let's dissect this case further. So what are the issues that we have in this patient? So naturally the patient has a poor glycemic control, but I'd like to see the data more closely. And I often see the delta value. So delta value is basically the postprandial sugar minus the fasting sugar, which is 64 over here. But his fasting is 212. So keep this in mind. I'll come back to this. Remember, मैं science के तरफ से हूँ, right? Okay. The patient has an increased creatinine. Now see, we have been told that the patient has CKD, but we don't know the baseline creatinine of this patient, right? We don't know the past history. We just know the current situation, right? And that is what happens in a lot of our practice. We don't know the etiology for the increased creatinine. We have the patient having AHCVD. He's having heart failure with reduced ejection fraction, slightly reduced ejection fraction, and he's having ongoing medicines, which are basal insulin, metformin with an SGLT2 inhibitor. Now, these are the options which are given to us. Add a GLP-1 receptor agonist, either an oral semaglutide or a liraglutide. Add a DPP-4 inhibitor. Add an AGI. Add a maglitinide, which is, Dr. Banshi Sabu is going to speak on this, and others. So, what is your answer? Well, allow you to think about it. We'll come back to this in a discussion. But my answer, I said in the beginning, I was to talk on GLP-1 receptor agonist, but my answer is none of the above. I'm not going to add this patient on a DPP-4, a GLP, a AGI, a maglitinide. No, I'm not going to do any of this. All I'm going to do in this patient is to fix the fasting first. I think that is the message which should be going today, right? The answer, in my opinion, and science ki taraf se, the answer is E, none of the above. The patient does not need any of these medication. All the patient needs here is to correct the basal insulin dose titration, right? That is all we need to do. Remember, no matter what the dose the patient is taking, right? There is a lot of wrong concepts about basal insulin. We don't know what dose this patient is taking. But whatever the dose is taking, the best thing about insulin is that you can always give more, right? So you can easily give this patient more basal insulin, titrate the basal insulin correctly. There is no upper limit of what basal insulin you can give. Remember, basal insulin is going to be the safest drug as well, right? Because, the patient has CKD, there are very few contraindications to use of basal insulin. This patient is already on basal insulin. All we need to do is titrate the basal insulin correctly. That is all we need to do, right? No other fancy medicines are required here, right? That is the science ki taraf se answer, right? So no new medicines. We see this type of patients very commonly in our practice. All you need to do is, first of all, review the patient's basal insulin technique and teach the correct technique. Every single day, I see patients with high doses of insulin, multiple doses of insulin, sugars are not under control, and you see this patient is having big lipohypertrophies on their abdomen, right? Patient is taking injection at the same site every day, right? Initially, the sugar was controlled for a few days. After that, the sugars are not under control. Half of the patients are not aware that they are supposed to change their pen needle. They don't know how frequently to change their pen needle. They don't know the correct technique for insulin injection. That's the most important thing. That is what we should be doing, right? So teach the patient the correct technique, check the patient's technique and teach the patient the right technique. Increase the dose of basal insulin. Ask the patient to report the fasting sugar daily by whatever means. Target to fix the fasting. Target a range of 90 to 130. And like Sir said, it's an elderly gentleman. Let's keep it 100, right? Keep it 100 to 130. What this will do is, remember the delta gap. Delta gap was 64. So I just bring the fasting down to, let's say, 100, right? 100 plus 64 is 164. The patient's postprandial will also come down to less than 180, right? And if you do the HbA1c after 3 months, patient's HbA1c will be easily less than 7, right? So remember the most important thing, right? In any patient, always, especially patients with high HbA1c, whenever you have higher HbA1c, the contribution of the fasting sugar is higher to the overall HbA1c. And hence, in all these patients, the important thing is to fix the fasting first, right? And in this patient, the fasting itself is 212. You don't need to do anything, just fix the fasting first. And we need basically, right, an agent which improves the fasting. And in this case, the patient is already on the best agent which can control the fasting, that is basal insulin, right? But we are, have to play the devil's advocate, right? I think this is I would say the correct answer, but we have to choose one of the drugs as we have been told, right? And in that scenario, right, let us look at the other options, right? So your GLP-1, your DPP-4, AGI, meglitinide. Well, answer 2, 3, and 4 are all wrong answers, because remember, we need a drug which corrects the fasting, and amongst all these 4 options, the only drug which has predominantly at good action, or not predominantly, I'll say good action on fasting is GLP-1 receptor agonist. That is a long-acting GLP-1, right? So we need a long-acting GLP-1, something like either a liraglutide or an oral semaglutide, which can have action on the fasting blood sugar. DPP-4 mainly has action on postprandial. AGI only has action on postprandial. Meglitinide has only action on postprandial. Patient fasting is 212. उसके postprandial is 264. उसको postprandial को और कम करके क्या करोगे? Right? कुछ नहीं करना है. Postprandial को नहीं touch करना है. Just correct the fasting, right? So, I don't know what Dr. Banshi sir is going to argue or what Dr. Agrawal is going to argue, but the simple point is, इसमें postprandial control करके there is nothing we are going to gain out of it, right? So of all the options which are available, the only viable option, right? Forget cardiovascular risk, forget CKD, everything. The only viable option is to either increase the basal insulin dose or to add a GLP-1 receptor agonist. These are the only options that we have, right? Now, the other big question here is the patient's, should the metformin be continued? Now, this is an important question, right? This patient's eGFR is 39. The patient is already on metformin, right? So what do? Should you continue metformin or should you discontinue metformin? That is an important question, right? So this is the guidelines from Korean Diabetes Society. Similar guidelines are followed all across the world, right? I chose the Korean one because it's the most well written, right? Remember, it is said that metformin can be used in full therapeutic doses when the eGFR is more than 45, right? If the patient is already on metformin and the eGFR is between 30 to 45, then you can continue metformin, but the dose should be less than 1 gram. And if the patient's eGFR is less than 30, then you do not initiate metformin, right? So that's the broad guideline. So in this case, we don't know the dose of the metformin the patient is taking, but the patient's eGFR is 39. That means up to 1 gram of metformin we can safely give to this patient. So Metformin, I will continue. If the patient's dose is more than 1 gram, I'll reduce it to 1 gram, but I will continue the metformin in this patient. Second important question, and Dr. Kamal Sharma sir is like a mentor and teacher to me, right? I've learned a lot from his book, and I knew that if this question is asked, there will be a SGLT2 there, right? I'm sure he's a big proponent of this very good molecule, right? Should you continue SGLT2 inhibitor in this? That's also important, right? So in this case, now we know that the patient has CKD, but we don't know whether this is acute on chronic or this is just a chronic kidney disease. We don't know the prior creatinine of this patient. So we are assuming that the patient is having CKD, right? We are assuming that the patient's creatinine has been stable, right? But what do you do if it was not, right? So if you see the KDIGO guideline about CKD, the KDIGO guideline says, again, we talked about metformin already, but about SGLT2 inhibitor, it says that if the eGFR is less than 30, do not initiate SGLT2. If the patient is on dialysis, discontinue SGLT2. But in other conditions, you can either continue SGLT2 or add SGLT2. In this case, patient is already on SGLT2 inhibitor, so you can continue that, right? And added to that, the other options you have are GLP, DPP4, insulin, AGI, and so on, right? But if you see the guidelines very clearly, it says the preferred drug is GLP-1 receptor agonist. So again, right, I may say anything, but the guidelines clearly say that the next preferred drug in this patient should be a GLP-1 receptor agonist, which of course, is the thing, right? And again, in simple terms, any patient with SGLT2, with CKD, remember if eGFR is more than 30, you can give, right, at any level of hyperglycemia. So you can give SGLT2 in this patient or continue SGLT2 in this case. When do you discontinue? Now what happens is if you add an SGLT2 inhibitor and there's an acute drop of eGFR, which is often hemodynamic in origin, if this drop is more than 30%, you discontinue the SGLT2 and reassess the patient. But if the drop is less than 10%, you can continue using the drug. So in this patient, you review the patient's past eGFR values. If you have that value, assess whether there is a recent drop in eGFR. If there is no recent drop in eGFR, you can continue your SGLT2. If the recent drop in eGFR is more than 30%, you need to discontinue SGLT2.
Last 1 minute.
Yes, sir. Okay, sir. What is the so with conclusion with SGLT2, you can continue SGLT2 in this patient. Now coming to GLP-1 receptor agonist, right? We need to consider two things here. First thing, can the patient afford a GLP-1? Second is, can the patient tolerate it, right? Any patient you start a patient on GLP, these two considerations should be there. Assuming that both these considerations are there, the arguments in favor of GLP are, you have good glycemic control, it helps in weight loss, it prevents CKD progression, and most importantly, prevents future cardiovascular events, right? If you see overall in terms of, the weight loss of oral semaglutide is definitely more sharper than sitagliptin, right? You can clearly see from this data, right? And again, if you talk about cardiovascular benefit here, remember this patient has ASCVD, patient has atherosclerotic cardiovascular disease, and the drug which is the best drug for preventing the progression of atherosclerotic cardiovascular disease, as we have seen from data earlier, is a GLP-1 receptor agonist, particularly in this patient, a Victoza oral liraglutide, right? Oral semaglutide, unfortunately, does not have cardiovascular benefit data. We have cardiovascular safety data, right? So this is the point here. HbA1c reduction is also the sharpest, again, with oral semaglutide. And most importantly, oral semaglutide can be given at any eGFR value. You can give it to any patient irrespective of the eGFR, and it can be easily given, and it is completely safe, right? So you can give it at varying degrees of renal impairment, and no dose adjustment is required. In fact, it is effective in patients with higher grades of CKD also, and it prevents the renal deterioration also, right? So again, we are all aware about the cardiovascular benefits of GLP-1 receptor agonist. And I think, I'm sure Dr. Banshi Sabu and Dr. Pankaj Agrawal sir will also agree with me that if cost is not an issue, then GLP-1 receptor agonist would be a great choice for this patient, right? So again, these are the other things. We'll not go into details about how, GLP-1 receptor agonist protects the cardiovascular system. You are all aware of this, right? But let us look at GLP-1 from a perspective of this being an ideal agent, right? It reduces HbA1c, fasting, and postprandial. It will produce minimum hypoglycemia. It will reduce the weight. It will have cardiovascular benefits, especially atherosclerotic cardiovascular benefits. Generally, side effects profiles are tolerable except for GI side effects. No dose requirement is required in old age, and no dose modification is required in this CKD situation. So there's no doubt about it that GLP is an ideal drug. The only factor is the cost here. right? That is the only factor in mind, right? So just to summarize, in this patient, remember, like I said, मैं science की तरफ से हूँ, ना मैं bride की तरफ से, ना bride groom की तरफ से. In this case, the best idea is to fix the fasting first. All the patient needs basically is proper basal insulin dose titration. The metformin can be given up to 1 gram in patients with eGFR between 30 to 45. SGLT2 may be continued. Of course, the benefit is definitely more than the risk in this patient and can be continued. GLP-1 receptor agonist is a great choice, provided the patient, two things: patient can afford it and patient can tolerate it. If both these things are taken into consideration, GLP is a great choice for this patient. In obese patient, GLP provides additional benefit of weight loss. And remember, in terms of atherosclerosis, GLP-1 receptor agonist is the best agent for the atherosclerotic prevention. And remember, in this patient, a combination of GLP-1 with an SGLT2 from a cardiovascular point of view will be, as a lot of us would say, and as Dr. Pankaj Agrawal would say in Hindi, "Sone pe suhaga." Right?
Very well taken, Om. You did very well, Om. It's a very big topic, but you summarized so well. Now we'll
are safer, oral, inexpensive and better alternatives. इसको डिस्कस करना चाहेंगे हम अगले कुछ मिनटों में. और जो हमारा मिशन है, मुझे आशा है कि आपको यह पसंद आएगा यदि हम अपनी इन्हीं डिस्कशंस को अपनी मातृभाषा हिंदी में करें. दो प्रश्न यहाँ आते हैं इस पेशेंट को देखते हुए. पहला, एक जनरलाइज्ड क्वेश्चन कि क्या हार्ट फेल्योर में DPP-4 इनहिबिटर्स सेफ हैं. दूसरा, इस पर्टिकुलर केस में यदि हम DPP-4 इनहिबिटर्स जोड़ें तो क्या वह फ्रूटफुल होगा, इसके लिए लाभकारी होगा. आइए इनको एक एक करके हम लोग डिस्कस करते हैं. DPP-4 इनहिबिटर्स हार्ट पर, स्पेशली हार्ट फेल्योर में, जो दो तरह से काम करते हैं, एज ए पार्ट ऑफ GLP-1 एंड एज एन इंडिपेंडेंट एजेंट. डॉक्टर ओम लखानी ने बहुत अच्छा GLP-1 एनालॉग्स के ऊपर बोला, बताया, और मैं उनसे पूरी तरह से सहमत हूं कि हमें साइंस की तरफ से होना है, ना कि किसी एक एजेंट की तरफ से. DPP-4 इनहिबिटर्स क्या है? GLP-1 एनालॉग्स और DPP-4 इनहिबिटर्स एक ही थैली के चट्टे बट्टे. DPP-4 इनहिबिटर्स फिजियोलॉजिकल मैनर में काम करते हैं, फिजियोलॉजिकल लेवल्स ऑफ GLP-1 को बढ़ाते हैं, और इसलिए उनकी लिमिटेड कैपेसिटी है. मैं इनको कहता हूं सल्फोनिलयूरियाज. और GLP-1 एनालॉग्स वो एक्सोजिनसली दिए गए GLP-1 एनालॉग्स हैं जो कि फार्माकोलॉजिकल कंसंट्रेशंस में GLP-1 को बढ़ाते हैं, और इसलिए इनकी पोटेंसी DPP-4 इनहिबिटर से बहुत ज्यादा होती है. इट्स जस्ट लाइक इंसुलिन. तो सल्फोनिलयूरिया से हम थोड़ा इफेक्ट अचीव करते हैं, इंसुलिन से हम, जैसा कि डॉक्टर ओम ने कहा, अनलिमिटेड. उसी तरह से DPP-4 इनहिबिटर से हम थोड़ा एफिकेसी हम ले सकते हैं, और GLP-1 एनालॉग से उसकी अपेक्षाकृत बहुत ज्यादा. लेकिन जो फार्माकोलॉजिकल कंसंट्रेशंस में जो इफेक्ट है, जो एडवांटेजेस बताए ओम ने, वह DPP-4 इनहिबिटर से हमें नहीं मिलते. DPP-4 इनहिबिटर्स के अपने इंडिपेंडेंट एक्शंस भी हैं. नाइट्रिक ऑक्साइड प्रोडक्शन बढ़ाता है, थोड़ा एंटी इन्फ्लेमेटरी रोल है इसका इंडिपेंडेंटली, और बहुत महत्वपूर्ण है कि BNP की मेटाबॉलिज्म में DPP-4 BNP को भी मेटाबोलाइज करता है, जो DPP-4 इनहिबिटर उसको कम करके BNP लेवल्स बढ़ा सकता है, और इस तरह से फ्रूटफुल हो सकता है. लेकिन यह जो पैथोफिजियोलॉजिकल मैकेनिज्म इसके लिए सजेस्ट की गई है, यह स्टडीज में बहुत अच्छे से अभी तक प्रूव नहीं हुई है. तो इतने एडवांटेजेस होने के बाद भी कंट्रोवर्सी क्या है? कंट्रोवर्सी शुरू तो हुई थी 2013 में सेवर्टी में ट्रायल, जो सक्सेग्लिप्टिन का ट्रायल था, जिसमें देखा गया कि हार्ट फेल्योर की इंसिडेंस 27% बढ़ गई, 1.27 हार्ट हैजार्ड रेशियो. इसी के बाद यह रिकमेंडेशंस आनी शुरू हुई कि नंबर 1 DPP-4 इनहिबिटर्स हार्ट फेल्योर या हार्ट में कोई बेनिफिशियल रिस्पांस तो देते नहीं, स्पेशली सक्सेग्लिप्टिन हमें ऐसे केसेस में अवॉइड करना चाहिए, और जो कि हम आज तक मानते चले आ रहे हैं. मैकेनिज्म क्या हो सकता है? शायद जो सिंपैथेटिक ओवर एक्टिवेशन, उससे इंड्यूस्ड कार्डियोमायोसाइट्स की अपोप्टोसिस, और शायद कुछ और पैथोफिजियोलॉजिकल मैकेनिज्म में जिनके द्वारा ये हार्ट फेल्योर जनरेट करते हैं। लेकिन 2013 से अभी तक बहुत बहुत लंबा सफर तय हो चुका। कई और स्टडीज में यह डाटा कभी आज तक रेसिप्रोकेट नहीं हो पाया। सेक्साग्लिप्टिन दोबारा किसी भी ऑब्जर्वेशनल स्टडी में उसने यह नहीं शो किया, यह नहीं प्रूव हुआ कि उससे हार्ट फेल्योर की प्रेवलेंस इंसिडेंस बढ़ती है। आप ये देखें 2 लाख पेशेंट्स में भी सेक्साग्लिप्टिन का हॉस्पिटलाइजेशन फॉर हार्ट फेल्योर उसके बाद दोबारा नहीं देखा गया। सिटाग्लिप्टिन 1 लाख एंड अबव पेशेंट्स में नहीं देखा गया। और जब डिफरेंट स्टडीज में और बड़े बड़े डाटा पर ये चीज ट्राई हुई तो देखा गया सिटाग्लिप्टिन वर्सेस सेक्साग्लिप्टिन कोई डिफरेंस नहीं है, और सल्फोनिलूरियाज के साथ भी बहुत कोई डिफरेंस नहीं है। तो सुर बदलने लगे। 2013 से 2018 आते आते क्या कहा जाने लगा कि देयर इज नो स्टैटिस्टिकल इंक्रीज रिस्क विद DPP4 इनहिबिटर्स इन रिस्क फॉर हार्ट फेल्योर। तो सेक्साग्लिप्टिन लेकिन अभी एक बार बदनाम हो चुकी तो क्या किया जाए, उसको हम अभी भी एक अलग कैटेगरी में रखते हैं। लेकिन बाकी DPP4 इनहिबिटर्स का जो ऑनगोइंग जितने भी क्लिनिकल ट्रायल्स हुए उनमें देखा जा रहा है किसी से और हार्ट फेल्योर के हॉस्पिटलाइजेशन का रिस्क नहीं बढ़ता। तो आज की स्थिति क्या है? आज का जो करंट लास्ट ईयर रिकमेंडेशंस है वो ये है कि डेफिनेटली इनसे सीवी बेनिफिट तो हमको नहीं मिलता, लेकिन दीज आर नॉट बैड एजेंट्स। तो 3rd 4th लाइन एजेंट के तौर पे आफ्टर SGLT2 इनहिबिटर्स, आफ्टर GLP-1 एनालॉग विच आर द प्रूवन ड्रग्स, उनके बाद मेटफॉर्मिन के बाद एज 3rd और एज 4th लाइन एजेंट हम DPP4 इनहिबिटर्स को यूज कर सकते हैं। अगर किस कार्डियोलॉजिस्ट के बीच में मैं इसको कहूं DPP4 इनहिबिटर्स को, तो मैं जो डिस्कशन अभी डॉक्टर अभिषेक के साथ हो रहा था, मैं कहूंगा कि DPP4s आर जस्ट लाइक एम्लोडिपिन। जैसे ये एम्लोडिपिन आप कहीं भी दे देते हैं और उसका कार्डियक पेशेंट, रीनल पेशेंट में बहुत ज्यादा डिफरेंस नहीं होता माइनर चेंजेस को छोड़ के, वैसे ही DPP4 इनहिबिटर्स हम लोग बेहिचक इस्तेमाल करते हैं, कहीं पे बहुत मेजर डिफरेंस नहीं आता। और मैं इसको इसीलिए कहता हूं ये तो आलू है, किसी भी सब्जी में डाल दो उसके साथ में चल जाएगा। तो अगला क्वेश्चन आता है, इस हमारे पर्टिकुलर केस में DPP4 इनहिबिटर्स की क्या पोजीशनिंग होनी चाहिए? हमारा प्रोफाइल अभी ओम ने अच्छे से डिस्कस कर ही चुके हैं। आइए एक एक करके हम इनके पहलुओं को समझते हैं। ओल्ड पेशेंट DPP4 इनहिबिटर्स बहुत सुरक्षित हैं और बहुत इफेक्टिव हैं, देयर इज नो डाउट। ओबेसिटी के साथ दे आर न्यूट्रल, इनसे वेट गेन भी नहीं होता, वेट लॉस भी नहीं होता। अगर ओबेसिटी को ध्यान में रखना हो तो डेफिनेटली SGLT2 इनहिबिटर और GLP-1 एनालॉग एक बेहतर चॉइस होगी। पोस्ट PTCA पेशेंट में डेफिनेटली ये न्यूट्रल है, इनसे कोई ना बेनिफिशियल रिस्पॉन्स है ना इनका कोई डिलीटेरियस रिस्पॉन्स है, और यहां पर भी SGLT2 इनहिबिटर्स और GLP-1 एनालॉग्स बेटर होंगे। मैं इसके लिए डॉक्टर ओम को और उनकी प्रेजेंटेशन को यहां पे प्रेफर करूंगा और कोट करूंगा। इजेक्शन फ्रैक्शन 48% कॉम्प्रोमाइज्ड है। यह वो जगह है जिसके कारण से अभी तक DPP4 इनहिबिटर्स जो डिस्प्यूटेड है, तो या तो वो न्यूट्रल है या सेक्साग्लिप्टिन के साथ देखा गया इट इज हजार्डस। और डाटा हमारे पास क्लियर कट है कि SGLT2 इनहिबिटर्स दे आर प्रेफरेबल एजेंट्स फॉर दिस ग्रुप ऑफ पेशेंट, तो उसको हमें प्रेफर करना है, वो हमारे पास ऑलरेडी चल रहा है। EGFR कॉम्प्रोमाइज्ड है, यहां पर DPP4 इनहिबिटर्स की क्या पोजीशनिंग होनी चाहिए? कॉम्प्रोमाइज्ड EGFR के साथ में DPP4 इनहिबिटर्स दिए जा सकते हैं, सुरक्षित हैं और इफेक्टिव हैं। अंतर क्या है? कुछ एजेंट्स जिनका डुअल मोड ऑफ एक्सक्रीशन है लाइक लेनाग्लिप्टिन, टेनेलिग्लिप्टिन, वह विदाउट डोज एडजस्टमेंट दिए जा सकते हैं, और बाकी सेटाग्लिप्टिन, विल्डाग्लिप्टिन, एलोग्लिप्टिन यह सब डोज एडजस्टमेंट के साथ दिए जा सकते हैं, लेकिन ये इफेक्टिव हैं और इनके कोई डिलीटेरियस रिस्पॉन्सेज नहीं दिखेगा। जो लास्ट और जो डायबिटोलॉजिस्ट के लिए सबसे महत्वपूर्ण जो पहलू आता है वो है HbA1c 8.9%। सारे DPP4 इनहिबिटर्स अमूमन 1% HbA1c को रिड्यूस करते हैं, और यहाँ पे ओम ने बहुत अच्छे से डिस्कस किया इस पहलू को कि अगर हम 7% का टारगेट भी ले तब भी 1.9% का एलिवेशन है, और 1.9% का एलिवेशन हम केवल DPP4 इनहिबिटर से नहीं ले सकते, तो यहाँ पे अगर हम DPP-4 पे ही भरोसा करके चलेंगे तो यह राह हमारी मुश्किल हो जाएगी, हमें किसी और का सहारा लेना पड़ेगा। लेकिन 1% HbA1c रिडक्शन से भी आप जानते हैं, मुझसे बेहतर जानते हैं कि 15% रिस्क हमारा हार्ट फेलियर का कम होता है। तो यह बहुत अच्छे एजेंट रहेंगे। फिर से जिस पहलू को हमने बहुत अच्छे से डिस्कस किया, मैं तारीफ करूंगा कि 212 to 76 जो डेल्टा फिगर जिस पे अभी लोग बहुत कम ध्यान देते हैं, वह उन्होंने पॉइंट उठाया। यहाँ पर 212 फास्टिंग एक बड़ा डिनोमिनेटर है और सिग्निफिकेंटली हाई HbA1c। तो मेटफॉर्मिन तो हमें चलाते रहना है, जिसकी के ऊपर डिस्कस हो चुका है कि EGFR के अकॉर्डिंग उसकी डोज डिसाइड करें। SGLT2 इनहिबिटर्स चलाते रहना है, पुनः इस बात को देखते हुए कि बहुत सीवियर कॉम्प्रोमाइज ना हो। यहाँ पर 38 है, कोई दिक्कत की बात नहीं। ग्लार्जीन हमें बढ़ानी है जब तक कि फास्टिंग हमारा नियर नॉर्मल लेवल पे ना आ जाए। DPP-4 इनहिबिटर्स अगर हम जोड़ ही रहे हैं तो हमें वह DPP-4 इनहिबिटर प्रेफर करना है जिसका कि बाई मोडल एक्सक्रीशन पैटर्न हो, लिनाग्लिप्टिन या टेनेलिग्लिप्टिन, जो हम फुल डोजेस में यहाँ पे फुल एफिकेसी के साथ इस्तेमाल कर सकें। और केवल ग्लार्जीन को देते हुए यदि हम PP को कंट्रोल नहीं कर पाते हैं, हालांकि ग्लार्जीन और DPP-4 इनहिबिटर के बाद कोई पहलू अनटच्ड नहीं रहना चाहिए, लेकिन अगर फिर भी आफ्टर ब्रेकफास्ट कंट्रोल हो गई, हमने देखा आफ्टर लंच बढ़ी हुई है, आफ्टर लंच कंट्रोल हो गई, आफ्टर डिनर बढ़ी हुई है, तो करस्पॉन्डिंग मील के पहले हम एक प्रेंडियल इंसुलिन जोड़ सकते हैं। तो डेफिनेटली इस प्रकार के पेशेंट्स में हम DPP-4 इनहिबिटर जोड़ तो सकते हैं, लेकिन यहाँ पे इस गिवन केस में ग्लार्जीन को बढ़ाना सबसे पहला पहलू होना चाहिए। DPP-4 इनहिबिटर्स को हम उसके साथ जोड़ सकते हैं, जैसा कि बात हुई कि GLP-1 एनालॉग होते तो बेहतर होता। तो मैं यहाँ पे विदाउट एनी आर्गुमेंट मैं सरेंडर कर रहा हूँ, मैं कोट कर रहा हूँ उनको कि GLP-1 एनालॉग्स अगर होते तो यहाँ पर बेटर होते। DPP-4 इनहिबिटर न्यूट्रल ही रहेंगे। और AGI मैग्नेटाइट के बारे में अभी आना है और बंसी बात करेंगे उसके विषय में। DPP-4 इनहिबिटर्स डेफिनेटली सेफर एजेंट्स हैं इस तरह के पेशेंट्स में भी, ओरल और इनएक्सपेंसिव आज 2022 में तो है ही, लेकिन मैं बेटर कहने से पहले बचना चाहूंगा। बेटर एजेंट्स नहीं है, बट दीज एजेंट्स कैन बी यूज्ड इन सच टाइप ऑफ पेशेंट्स। धन्यवाद। मैं समझता हूँ चेयरपर्सन मैंने अपने टाइम के अंदर ही खत्म किया और डिस्कशन के लिए मैं उपलब्ध रहूंगा।
First of all, thanks Kamal for giving me an opportunity. Om was talking for first 5 minutes that case is wrong. I agree that the fasting sugar was not controlled, and let us assume that glargine is given in full dose, and let us consider that fasting sugar is 112. And Kamal and Dr. Apurva had referred the patient for control of the sugar with 8.9 A1C. So now understand that this patient is already on insulin, full dose, and he's having fasting sugar of 112 with 276. Already Dr. Pankaj has talked about the DPP-4, but he agreed that GLP-1 is the best, and that we, as far as science is concerned, we agree and we will go with the guidelines also. But where I will place that, should I put the patients on a glinides or on alpha-glucosidase inhibitor in combination? Because patient has been referred from cardiologist and nephrologist for a good control of diabetes with 8.9 is not acceptable. Even the patient may be a 72-year-old guy, or he is having a patient with a post-PTCA or his LV dysfunction. So this is the case. We all know now. I did not need to discuss more about it. So the guideline approach, fully I agree that this patient should have achieved the A1C of around 7.5. And there should not be further weight increase, which GLP-1 will be best. Cardiorenal prospective anti-diabetic agents, if patient is already on SGLT2 inhibitor, we would like to put the patients on GLP-1, and glargine will take care of the fasting sugar. But in real world, it does not work. And that is what, even after next 5 minutes, again, we could not convince that patient should be started on GLP-1 or not. Are we adherent to the guidelines which is recommended therapy? And this is the data which is published in 2019. And even from the Western world, where these molecules are available to the patients free of charge, and still the clinicians are not writing the way they should write, or the guideline-based therapy. Here you can see less than 10% of the patients with type 2 diabetes with cardiovascular disease received guideline recommended therapy for CV risk reduction even in developed world. And this is the data which I am showing, which is published in 2019. Now, attaining A1C for these patients, I am sure all of you will agree that patients should achieve a A1C of less than 7.5. If not very good tight control, we don't want hypoglycemia, but definitely HbA1c should be around 7.5. Hyperglycemia itself leads to a lot of problem, even in a person who is not having cardiovascular disease or somebody who is having already cardiovascular disease, because PPSG is a postprandial hyperglycemia associated with hypercoagulability, including increasing platelet activity and activating platelets. And there are multiple other reasons for which postprandial hyperglycemia has to be controlled, not only just for getting A1C to get control. If I just put the list of all the anti-diabetic agents which are available to us, and this patient is already on SGLT2 and metformin, can we give the patient sulfonylurea? Risk of hypo is more. Glitazone may precipitate heart failure. SGLT2 patient is already there. GLP-1, yes, it's a choice of drug, but the GI issue, the cost, pancreatitis, needle prick, even though now it is available in oral form, but the cost is a major challenge. Alpha glucosidase inhibitor safely can be given with eGFR up to 25. This patient is having 39. The glinides can be given even in the patient with CKD and end-stage renal disease. You can give up to 0.5. 0.5 can be given further broken in half tablet as per the dose, as patient should not develop the hypoglycemia, and at the same time post-meal glucose has to be controlled. Now this is the data, I'm sure all of you agree, and you know it also that which anti-diabetic therapy can be given in different stages of CKD. And it is the glinides which can be given in the patient even his eGFR is less than 25. Even we can give it even in end-stage renal disease where the eGFR is even less than 15 also. So this is safely can be given in the patient with CKD, and this patient is having a progressing chronic kidney failure. Now, as far as efficacy is concerned, now this patient is 8.9, considering the fasting sugar is 112 and glargine dose is full given, still the A1C is not getting control. Now, what molecule would you like to give? You have a choice of GLP-1 and DPP-4 with the average A1C reduction as a third line agent will be 0.5 to 1.1. And you can see here with the sulfonylurea, glinides and alpha glucosidase inhibitor, they are highly efficacious drug, because now this patient's major concern is a postprandial hyperglycemia. If I can achieve the glycemic control or the post-meal glucose level from 250 to 150, the A1C reduction will be almost in the tune of 1.5 or 1.3, and that you can achieve only by AGI or glinides or a short-acting sulfonylurea, which will not be possible with DPP-4 and GLP-1 analog. And that's the reason the patient can be, for a good glycemic control, the glinides and alpha glucosidase inhibitor can be a choice of therapy. Is postprandial glycemia harmful? We all know it. International Diabetic Federation had come out with a special booklet which is talking about the post-meal hyperglycemia is a harmful and it should be addressed. And what they are talking, the several class of pharmacological agents which can preferentially lower the PPG, but it is AGI and glinides are a choice of therapy when we are trying to talk about only post-meal glucose to get control. The American Diabetic Association recommends, even they don't talk about the post-meal glucose so much and they don't talk about the AGI, but they talk that it is clear that postprandial glucose level, like preprandial hyperglycemia, it contributes to elevated A1C level, and its relative contribution is being greater when A1C is closer to 7. So when you are looking at the patient whose A1C is around 8 or 8.5, try to control the post-meal glucose level also along with fasting control. If your fasting is controlled and still the A1C is around 8 or 8.5, try to achieve the tighter control of the glucose also. The RSSDI, we also recommend the same, that post-meal glucose level should be less than 160. It is AGI, GLP-1, DPP-4, all of them are also working on post-meal glucose level, but glinides and short-acting sulfonylurea are recommended in a patient with CKD who have a post-meal glucose level are high. Now let me talk about this combination where the talk is given to me, what repaglinide and voglibose does. Rapid and short-acting insulinotropic oral hypoglycemic agent, and AGI is a class of agent which is competitive inhibitor of enzyme needed to digest the carbohydrate. In very simple language, this combination takes care of both the parts and they can be combined in a patient who is already the post-meal glucose is not getting controlled. Repaglinide is a glucose dependent. It does not cause so much longer hypoglycemia. It restores early phase of insulin secretion, improves post-meal glycemia and reduces lipolysis, and it is recommended by various societies, and particularly when PPG is associated with diabetes and CKD, the glinides is a choice of therapy. It exerts direct action on a pancreatic beta cell, but it is unlike sulfonylurea, so the chances of hypoglycemia with glinides are very, very less. It has got an insulinotropic action at a glance, but there are other benefits. It improves beta cell function, it restores early phase insulin secretion, and rapid onset of action with short-lived hypoglycemia effect, and it's a glucose and dose dependent insulinotropic effect. It is other like a glimepiride. It does not cause long-acting hypoglycemia, and it is only controlling the post-glucose excursion only. But the point is here, whether it can be given in a patient who is post-PTCA, a 72-year-old guy. Repaglinide is more efficient than controlling the post-meal glucose excursion, and it has got a beneficial effect on reducing cardiovascular risk factor, for which I will show one more paper that. Repaglinide CV safety data. Repaglinide associated with lower cardiovascular risk than any other insulin secretagogue. So if out of all sulfonylurea, if I put, then the glinides, I am not comparing here it with the GLP-1 or SGLT2. So mind well, but here out of all the sulfonylurea, if we want to control, the glinides are safe as far as no previous myocardial infarction, those patients, cardiovascular death, or the patient who have MI, stroke, or cardiovascular death. The voglibose, it inhibits absorption of carbohydrates from intestine. The inhibitory activity on maltose and sucrose is 190 to 200 times, 70 times higher than a carbose. It reduces oxidative stress. Voglibose lowers the daily glycemic excursion. It increases the release of GLP-1 and had got a better safety profile in compared to other oral hypoglycemic agents. Voglibose prevents post-meal glucose excursion. It reduces post-glucose excursion. It delayed distal intestinal absorption and carbohydrates. It also increases the GLP-1 level, which helps in delaying the gastric emptying and decrease appetite, and there is a weight loss also. Why repaglinide and voglibose combination can be given? The combination provides better efficacy compared to monotherapy. It is a rationale for doubt in patients who have prandial regulators are needed. AGI modified rapid insulin release, which is induced by repaglinide with different mechanism of action. Both the molecules actually they supplement each other, and there is no evidence of clinically significant pharmacokinetic interaction between glinides and voglibose. If you just see the data that along glinides, if compared to that, if you put the repaglinide and voglibose, there is a significant decrease in the post-meal glucose level. As far as hypoglycemia is concerned, if you combine both instead of only repaglinide, the frequency of hypoglycemia is significantly decreased, because sudden chance of post-meal hypoglycemia will be decreased by adding the voglibose. So the combination have less risk of hypoglycemia and a better control also. So in which condition or useful condition when it can be used? The typical condition is a type 2 diabetic patient with CKD, and definitely the patient with irregular meal pattern, or the patient who have high carbohydrate content, even after explaining the patient or nutrition counseling has been done. To summarize my talk, repaglinide with alpha glucosidase inhibitor, that's voglibose, will provide better efficacy to control post-meal hyperglycemia. Both of them have a different mechanism of action. Therefore, combination will have a synergistic action, and no evidence of clinically significant pharmacokinetic interaction between repaglinide and voglibose. Combination was weight neutral, had fewer hypoglycemia events than in compared to monotherapy. To take away from this complete debate, we all understand that diabetes and cardiovascular disease are both global epidemics, and we have to accept that as a person with diabetes, with the 72 years old guy, the patient should be given a choice of a therapy which is most CV safe and CV benefit. The post-meal glucose level itself is a problem with the patient with CKD, and it is again higher associated with CV and mortality risk and additional risk factor of hypertension and dyslipidemia. By adding alpha glucosidase inhibitor, we are benefiting the surrogate markers of CVD and maybe useful drug for reducing cardiovascular risk by reducing postprandial hyperglycemia, by decreasing glycemic excursion. It improves vascular health, reduces oxidative stress, and prevents endothelial dysfunction. It promotes weight loss. It improves blood pressure and decreases risk of hypertension. It inhibits platelet activation, and it improves gut dysbiosis. In real-world data, it demonstrated significant lower risk with the use of AZA and glinides combination for risk of hypoglycemia, particularly in patients of CKD. With this, I thank, but I'm
Hi, I'm Dr. Kamal Sharma, an interventional cardiologist from Ahmedabad. This is a disclosure, as mentioned in the slide, for being on board as advisor to the company. AMS has detailed US audits with Boston Scientific, B. Braun, and Johnson & Johnson. It's a Singapore-based headquartered company which is dedicated to bringing highest quality of medical device technology to affordable cost in countries across the world. Mr. Vijay Keval Ramani and Dr. Parag Saxena have been the US promoters who have been global entrepreneurs. Parag has been chief advisor to some of the most important heads of the state across the world, including President Joe Biden and our own Prime Minister Narendra Modi. Manuel Perente is AMS chief advisor for interventional technologies, and he is the nicknamed balloon master, as he invented the first US FDA approved balloon catheter, which was designed for Maverick for the Boston Scientific company for the balloon dilatation. He has done a technology transfer to AMS to create the next generation of PTCA balloon catheters. AMS is a state-of-the-art manufacturing infrastructure which is located at Vadodara, our own Gujarat, built across 150,000 feet across 10.5 acres of land. It has been sourced best in the class equipment and machinery for manufacturing and testing, ensuring the highest quality of standards. The emphasis is on all quality management pillars, that is planning, control, assurance, and improvement. And it has got in-house testing and microbiological lab with best in the class equipment with certification from ISO 13485 and CE through DNV Norway. So they have products like Advaglide PTCA balloon catheter, and they have NC Advaglide, which is the non-compliant balloon which is used with the gliding of using the technology of science of flow restoration in the gliding smooth manner. The special features of Advaglide tip is that it's flexible atraumatic tip design which minimizes intimal injury. The tip entry profile is 0.016 for crossing tough lesions with minimal 5 fringe guiding catheter compatibility designed for small vessel disease. Maximal guide wire compatibility is of with 0.14 and entering tip profile is the minimal in the industry class of 0.4 millimeters with compatibility with 0.14 with guiding catheter 5 fringe compatibility. So as you can see for the slides, you have brand A, B, and C. Only brand A is what stands with the Advaglide here, but the other two have much bigger profile to cross. So this is the ideal for accessing complex tight lesions, including chronic total occlusions, and tip entry profile measurements of just 2 millimeter diameter for Advaglide is the test data from the AMS that has been now documented. The superior material and design for enhanced performance allows the AMS selected nylon 1.25 from testing 248 different materials. This is the thinnest balloon catheter material, which provides wall thickness of 0.008 millimeters with nylon L25, allowing RBP of 18 bars with resistance up to more than 25 bars. Enhancing design by 42° at conical part of the balloon, high flexibility of the distal end, which is the new design technology in this balloon catheter, allowing it a better entry into the chronic occlusions and good crossability with minimal profile. The trifold balloon wrapping results in low profile, and so does the balloon material, which ensures shape retention on repeated inflation with faster deflation time. So it's ideal for CTO and has got the lowest crossing profile of 0.56 for 1.25 and 0.74 for 4.5 millimeter balloons. It's best in the class pushability for most complex lesions. The average force transmission to push the balloon catheter for proximal to distal end with higher force transmission, which leads to a better pushability. So you can see EdvaGlide is 0.9 force transmission in terms of newtons compared to the brand ABC, which are much lesser, which allows much higher and better pushability with smaller profile to cross all the lesions across the class. So there is precision, perfection, and a professional or a pro approach, as they call, for EdvaGlide Pro, which is designed to deliver a safe performance. EdvaGlide Pro is designed on cobalt chromium platform with thin strut thickness of 65 microns with open and closed cell design, which allows excellent safe branch access with enhanced deliverability with Swiss technology for stent delivery catheter. Coating of the same on abdominal surface gives a targeted drug release in the arterial wall with biodegradable polymer matrix of poly-DL lactide, which is one of the best in the class. Also, it controls the neointimal proliferation by action on cell cycle, and sirolimus drug is the drug platform that it uses, which has got anti-inflammatory, anti-proliferative cytostatic drug and blocks the transmission from G1 to S phase, acting on the mTOR and SMC migration on healing. The cobalt chromium alloy of L605, which is 65 micron strut with zero foreshortening design with recoil of less than 5%, gives a metal to artery ratio of less than 18% with crossing profile of 0.95 to 1.1 millimeter. The size-based design, which is small, medium or large vessel, can be done for 6, 8 and 10 crown, and S-link for better retention force by along with 2 link structures, allowing it for flexibility. Low crimping profile makes a crossing profile of 0.95 to 1.1 and excellent crossability and increased deliverability in difficult lesions with exceptional side branch across open to cell design. So this is a life-enhancing innovation in terms of the catheter technology. AMS Everliver stent is launching later this year along with many other enhancing innovations. AMS product portfolio ensures superior quality and reliability to deliver successful clinical performance. So you have comprehensive portfolio like EdvaWire, angiographic catheter, which is hydrophilic coated, aspiration catheters, Edva inflation devices, PTCA kits, hemostasis, 3-way stopcocks, Edva sheath, which is an introducer sheath, and 2-port and 3-port manifold, which are now important devices all across the spectrum. So soon you will have Edva ACE, which is going to be the everlimus eluting stent on the precision ACE technology, which will be launching soon by the AMS. So thank you very much, and I again say that I'm on the advisory panel for the AMS, and this recording is done as part in good faith of the same. Thank you very much. Take care. Keep connected. Let the science grow. Bye-bye.